The subcommittee will come to order. The chair recognizes myself for an opening statement. Over the past several weeks, the Health Subcommittee has led the way, bringing forward solutions to address some of the biggest challenges facing patients in our healthcare system. Today, we're continuing that effort by advancing critical legislation that will help patients access life-saving cures, enable seniors to continue receiving care from the comfort of their homes, strengthen the Medicaid program for vulnerable patients, and support our workforce so that every American can get the care they need. Now we have FDA-approved therapies that in many instances are the only treatments available for rare disease patients and their families. Part of the reason for the rapid development of these therapies is because of the congressionally established Pediatric Rare Disease Priority Review Voucher Program in 2012. Over 50 vouchers have been awarded as a result of this program, 39 for pediatric rare diseases, and over half of which have been awarded over the past 5 years. That's why I'm glad we're considering legislation which would continue life-saving access to therapies for kids living with rare diseases who currently lack any access to any treatments. I would like to thank Representative Bilirakis for his leadership on this legislation and encourage my colleagues to support advancing the bill to the full committee today. The acceleration of telehealth has also transformed our healthcare system, especially following the COVID-19 pandemic. Over 30 million seniors in Medicare utilized telehealth services throughout the first months of the pandemic, giving beneficiaries the chance to have routine healthcare visits from the comfort of their homes. Congress extended these flexibilities beyond the public health emergency, where they're set to expire at the end of the year. I would like to thank Representative Carter for his steadfast leadership on H.R. 7623, the Telehealth Modernization Act of 2024. This legislation serves as important guideposts of work we're doing today. This policy extends to the current telehealth flexibilities in our committee's jurisdiction for an additional 2 years and includes other reforms. While we have seen a number of positive developments in health over the past decade, not everything has been positive. We have seen an explosion in the rate of improper payments in the Medicaid program, reaching $50 billion in improper payments in 2022 alone. The Energy and Commerce Committee has done extensive work over the past several years to address these challenges, most recently considered a number of legislative solutions to stabilize the program. Among these ideas, we will be considering 4 bills that take steps to addressing key program integrity issues facing the Medicaid program, such as increasing the frequency that state Medicaid programs check to make sure they are not paying for deceased beneficiaries, and requiring regular updates of address information for beneficiaries so we don't pay for care for people who live out of state. I would like to thank Representatives Bilirakis, D'Esposito, Garcia, and Miller-Meeks for leading these bills and encourage my colleagues to support this legislation. Last, but certainly not least, we will be considering legislation to support our workforce and improve access to care for Americans across the country. This includes the Accelerating Kids Access to Care Act, which will cut red tape for pediatricians, and my bill, H.R. 468, the Building America's Healthcare Workforce Act, which will help build more robust workforce pipeline for our nation's nursing homes. Both bills come at a critical moment of our country. Our healthcare system is facing stark workforce shortages that existed before the pandemic, but only have grown more severe in recent years. Since 2020, over 500 nursing homes have closed across the United States, and another 150,000 nurses are needed to reach pre-pandemic staffing levels. In closing, I would like to thank my colleagues for bringing forth the solutions we're advancing today. Patients, providers, and taxpayers will greatly benefit from the important bipartisan work we're doing today. I yield back and recognize the gentlelady from California, the ranking member, for 5 minutes for her opening statement.
Thank you, Mr. Chairman, and good morning, colleagues. Today we will consider 23 bills, with most being bipartisan, which is wonderful. These important bills will help the oldest and the youngest amongst us to receive high-quality care. First, we'll consider several bills to extend Medicare coverage for telehealth, cardiac rehabilitation, and remote patient monitoring. Second, we'll consider the Accelerating Kids Access to Care Act, sponsored by Representatives Trahan and Miller-Meeks. This bill needs to become law because it will allow children with Medicaid coverage to receive life-saving specialized care across state lines. Third, we'll consider 3 bills to improve access to life-saving treatments for people with a rare disease, especially children. Earlier this Congress, I, along with the chair of the Childhood Cancer Caucus, Representative Michael McCall, introduced a package of bipartisan bills to make sure that children with rare diseases receive safe and effective treatment. First, we introduced the Give Kids a Chance Act to authorize the FDA to direct clinical trials of combination therapies in children. Currently, the FDA can direct trials of combination therapies for adults, but not for children. Our bill gives FDA that authority. Today, more than half of the House, 232 bipartisan members, have co-sponsored the bill, and every member of this committee voted for it as part of user fees last Congress. Give Kids a Chance will be marked up today, and I look forward to this bill becoming law this year. Second, we introduced the carrot of the Creating Hope Reauthorization Act to continue incentives for pediatric research by granting valuable priority review vouchers to drug makers who market treatments for rare pediatric diseases. Creating Hope will also be marked up today. Third, we introduced the stick, so to speak, of the Innovation in Pediatric Drugs Act. This legislation requires drugs for rare diseases to be studied in children after being approved for adults. The legislation also puts kids on an equal playing field with adults by allowing FDA to enforce post-market pediatric studies the same way the FDA enforces required post-market studies for adults. Unfortunately, we haven't reached a bipartisan agreement yet on this bill, and it was not included in the markup. I plan to offer it as an amendment and to continue bipartisan negotiations so a complete package of bills can be brought to the full committee. The package should preserve the delicate balance between ensuring pediatric research is conducted on drugs approved for adults while also providing financial incentives for the companies who do the work of creating new pediatric products. This is the model that Congress has used successfully for pediatric research for over 20 years since the passage of the Pediatric Research Equity Act and the Best Pharmaceuticals for Children Act. Over 1,110 drug labels have been updated to reflect new pediatric information since these two laws took effect. We should use the same model and approach today, and I look forward to a productive market, and I yield back, Mr. Chairman.
Thank you. The gentlelady yields back, and the chair recognizes the chair of the full committee, Chair Rogers, for 5 minutes for an opening statement.
Good morning. Thank you, Chair Guthrie. Today, we consider bipartisan legislation to extend telehealth flexibilities that are set to expire at the end of the year. While continuing these flexibilities for seniors will require an investment by Congress, it is crucial that we continue to allow seniors to access health care via telehealth if they choose. The bills we are considering today will protect seniors' access to telehealth for an additional 2 years. They improve upon the bipartisan work of past Congresses by adding new program integrity safeguards, and some of the bills will also expand how seniors can benefit from telehealth. I commend Representatives Carter, Joyce, Alderson, James, Bilirakis, and many other members on both sides of the aisle for their continued hard work on advancing these policies. Telehealth has proven to be vital for patients across the country, especially in rural areas like my district in Eastern Washington. I look forward to advancing legislation today and am committed to continuing working to address any outstanding concerns and to ensuring the legislation is fully paid for before we consider them at the full committee. I'm also pleased that we're considering several bipartisan bills to support and build upon efforts to increase access to care, raise awareness, and improve coordination across our federal government for programs related to autism and lung cancer. Lastly, the committee is working on a 6-year reauthorization of the Rare Pediatric Disease Priority Review Voucher Program ahead of its September 30th expiration. We've heard testimony on the importance of this program, and this week, the Dion family has been meeting with offices to share their story. When Peter and Maggie Dion were born, they were each discharged from the hospital with a clean bill of health and initially seemed to be hitting their developmental milestones. Peter loved to fish for tuna with his dad. Maggie enjoyed dance and running with her mom. Everything changed when Peter was almost 10 and was struggling to climb up a set of stairs. Peter was diagnosed with a form of muscular dystrophy, limb girdle type 2C. Later that year, then his 6-year-old sister, Maggie, was also diagnosed with the same disease. This type of muscular dystrophy is a rapidly progressive muscle wasting disease, and there is currently no cure. As their father put it, there are so many genetic variations. Doctors ran out of letters in the alphabet to identify the condition. The prevalence of the disease is low, as is, and with over 30 subtypes of the disease, each requiring a different gene replacement therapy, spurring the much-needed research and development proves challenging without additional incentives. Without the Rare Pediatric Disease Priority Review Voucher Program, Maggie and Peter's parents say their chances of getting treatments for their kids almost becomes impossible. For anyone who doubts why this program is needed, I urge you to consider the Dion family and their story. And sadly, it is a story known to many families. Just this week, the National Organization of Rare Diseases, which represents patients with rare diseases and their families, released analysis of the importance of the PRV program. It is clear from their analysis that the program is successful, but the report also provides important insights on how long it can take to see that success. Drugs take years and hundreds of millions or even billions of dollars to develop. While the Rare Pediatric PRV program was started in 2012, more than half of the designations, awards, and voucher redemptions came in the last 4 years. I want to thank Mr. Bilirakis, Ms. Eshu, and many others for their work on the rare disease legislation being considered today. These bills will strengthen the orphan drug pathway, make sure drugs are studied for children battling cancer, and continue the important PRV program. I'm proud of all the work and patient voices reflected in the legislation before us. I also know that more can and should be done. This subcommittee has heard testimony on many other proposals, such as my legislation to improve access to home and community-based services in Medicaid, and I look forward to continuing to work with members to move those forward in the future. Thank you, and I yield back.
The chair yields back, and the chair recognizes the ranking member of the full committee, Ranking Member Plone, for 5 minutes for opening statement.
Thank you, Mr. Chairman. Today, the subcommittee will mark up 23 bills, many that I will support and others that I will unfortunately have to oppose. We'll begin by considering bipartisan telehealth legislation that would expand access to telehealth services for 2 additional years, and the expansion of telehealth flexibilities has allowed Medicare beneficiaries to continue to receive telehealth services and help advance health equity by providing critical services to hard-to-reach populations and underserved communities. The bipartisan legislation we're considering would extend key telehealth flexibilities for 2 additional years until the end of 2026. As Congress continues to extend these, it's critical that we assess and monitor the quality of telehealth services to ensure that Medicare beneficiaries are receiving high-value, high-quality care. And I'm pleased the legislation that will give the Centers for Medicare and Medicaid Services the tools necessary to do this important work. And I'm also pleased that the bill will help strengthen program integrity by requiring CMS to collect additional data elements. Expanding access to telehealth is important, but we also need to make sure that patients can access these services, and that's why I'm deeply concerned that the House Republican leadership has refused to extend the Affordable Connectivity Program, which makes internet access more affordable for more than 24 million American households. It's time for my Republican colleagues to join Democrats and renew funding for this critical program. We're also considering several Medicare bills that are likely to have scoring implications, and we still don't have feedback from the Congressional Budget Office. While we'll advance these proposals on a bipartisan basis today, it's critical that these policies do not increase seniors' cost sharing and premiums or result in cuts to the Medicare program. and I won't support them going forward unless we can ensure that Medicare beneficiaries are fully protected from any cost increases. I'm also pleased that we'll mark up H.R. 4758, the Accelerating Kids Access to Care Act. This common-sense bipartisan bill will help children receive the care they need and give their parents and caretakers one less challenge to navigate. I look forward to working with Chair Rogers and the sponsors, Representative Trahan and Miller Meeks, to get this bill signed into law. Next, we'll consider several bills that amend the Food and Drug Administration's authorities. Some of these bills, like the RARE Act, have been the result of significant bipartisan efforts to come to an agreement on meaningful policies. However, the overall package of legislation included here does not appropriately balance incentives for drug companies and their responsibilities to ensure the needs of pediatric patients are met. My Republican colleagues have included H.R. 7384, which reauthorizes the Rare Pediatric Disease Priority Review Voucher Program without having concrete evidence that the program has been effective in stimulating development or providing expedited patient access to these drugs. We've said since the last reauthorization that we would need to carefully scrutinize whether this program achieved the impact Congress intended, but I don't think that that's been done. And we nonetheless tried to work to get to a bipartisan agreement, but unfortunately, Republican colleagues have refused to work with us on this, and Republicans should have included Ranking Member Eshu's bill, the Innovation in Pediatric Drugs Act, which requires drugs for rare diseases to be studied in children and provides FDA with the authority to penalize companies that do not complete their required pediatric studies on time. If we're talking about getting more innovative pediatric drugs to market, we need to address the barriers in current law to this drug development. Including this legislation in our markup today would have provided the appropriate balance needed in this discussion. Unfortunately, our Republican colleagues were unwilling to work with us to come to an agreement on any of the pieces of Ranking Member Eshu's bill, and that's disappointing, and for that reason, I can't support H.R. 7384 today. I'm also disappointed that we're marking up two bills that would have a negative effect on nursing home quality of care. H.R. 3227 and H.R. 468 would unwind basic but important protections for training and employing nurse aides in nursing homes. Doing away with these protections does not solve nursing home staffing challenges. It just creates a race to the bottom. It leaves nurse aides to work in increasingly unsafe and understaffed settings and elderly and disabled Americans without the quality care they deserve. And with that, Mr. Chairman, I yield back the balance of my time. Thank you.
Gentleman yields back. Are there any other members seeking for an opening statement? Seeing none, we will move to the first bill, and the chair calls up H.R. 3227 and asks the clerk to report.
H.R. 3227, a bill to amend Titles 18 and 19 of the Social Security Act with respect to nursing facility requirements and for other purposes.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? Gentleman from Indiana.
Mr. Chairman, I have an amendment at the desk.
The clerk will, is there any discussion on the bill first? Yes. On the bill before the amendment process? Yes. Okay. So we're going to have a discussion on the bill before the amendment, So the chair recognizes the ranking member.
I mentioned my opposition to this in my opening statement. The Ensuring Senior Access to Quality Care Act would undo current law restrictions that prohibit certain nursing homes from conducting in-house nurse aid training programs for 2 years. These nursing homes have received penalties above a certain threshold or have serious quality of care violations. Republicans claim that this change is needed to keep nurse aid training programs operational and address workforce shortages, but that argument just doesn't hold up. Nursing homes that are prohibited from operating nurse aid training programs already have a path forward for reinstatement of these programs. Under current law, if a nursing home has violations serious enough to require the suspension of its nurse aid training program and the disapproval was unrelated to the quality of care provided to residents, then that nursing home can receive a waiver to continue its training program. But this bill would moot that waiver process and allow nursing homes with deficiencies to continue to operate nurse aid training programs even if they committed potentially egregious violations, like falsifying records or failing to report resident abuse or a reasonable suspicion of a crime against a nursing home resident. So allowing poor-performing nursing homes to train the next class of workers doesn't solve the workforce shortage problem. It just basically begs for new problems to occur. So I urge my colleagues to vote no on this bill. And with that, I yield back, Mr. Chairman. Thank you.
The gentleman yields back. Any else seeking discussion on the bill? Seeing, gentlelady from Michigan, what purpose do you seek recognition?
Whoops, I moved to strike the last word.
Gentlelady's recognized.
Thank you, Mr. Chairman. We can all agree that nursing homes operating their own certified nursing assistant training program is a helpful way to combat the nursing shortage. However, if quality violations do occur, the Secretary of Health and Human Services must have the ability to provide checks on these systems. The Ensuring Seniors Access to Quality Care Act would reduce the oversight from HHS, and I cannot support it in its current form. The bill would repeal certain restrictions under Medicare and Medicaid that prohibit facilities with substandard care from training nurse aides. If deficiencies in quality of care are corrected, poor-performing facilities would be able to resume their training programs. However, this bill does not clearly define quality of care, making it difficult to implement these guidelines. Additionally, other egregious violations that are not related to the quality of care should still prevent facilities from training workers, such as record falsification, failure to report resident abuse, or reasonable suspicion of a crime against a resident, and retaliation against whistleblowers. Growing the long-term workforce is an urgent priority, and I'm never going to stop working for that. But we cannot do this at the expense of the health and safety of over 1.4 million Americans living in nursing homes. It is our responsibility to ensure that this workforce is sufficiently trained and supported to provide high-quality care for these Americans and their families. The bill contains no clear definition of what quality of care means, which would lead to confusion and result in disparate outcomes across the country. Critically, there are egregious violations that might not be related to quality of care that should still disqualify. We are in a critical time where nursing home residents are forced to live in facilities with inadequate staffing, and workers are confronted daily with a myriad of challenges, including poor wages and benefits, inadequate training, and few career advancement opportunities. I hope we can all work together to address it. It's a crisis in this country, only growing worse, but this bill does not do it, and I urge my colleagues to join me in voting no on H.R. 3327, and I yield back the balance of my time.
Gentlelady yields back. Anyone else seeking discussion on the bill? Seeing none, are there any bipartisan amendments to the bill? Seeing none, are there any other amendments to the bill? Gentleman from Indiana is recognized.
You know, I hear almost every day from my constituents about the crisis of our healthcare system is facing due to workforce shortages. Nowhere is this more acute than in our nursing homes. I'm proud to have championed this issue. I recently introduced a Congressional Review Act to prevent the Biden administration's disastrous nursing home staffing ratio rule. We've had some hearings here where we know there aren't enough nurses out there, so I guess I don't want to go to no care. I think we've got to find solutions here and not just do whatever the Biden administration wants us to do. This bill is pretty straightforward today. It clarifies that nursing homes that have been subject to civil monetary penalties that are unrelated to patients' care should not have their ability to train staff revoked. This preserves the current prohibition on training staff in facilities where patient harm and quality are at risk. President Biden is advocating for staffing ratios in nursing homes without providing a solution to actually train more workers and to get them in the facilities. This bill will do that. Mr. Chairman, I yield back.
Does the gentleman have an amendment at the desk? I believe the gentleman has an amendment at the desk.
I do have an amendment at the
The
desk.
clerk will report.
Amendment in the nature of a substitute to H.R. 3227, offered by Mr. Pence.
Without objection, the reading of the amendment is dispensed with. The gentleman has discussed his amendment. Is there any further discussion? Begin with gentleman from California, recognized for 5 minutes on the amendment.
Thank you very much, Mr. Chairman. I move to strike the last word. I want to again highlight the importance of listening to the voice of long-term care workers who have been clear about the difficulty they face in strengthening their workforce. Undermining standards for the workforce providing essential care to our nation's seniors would be harmful to our shared goal of ensuring quality and dignified care for all. We must stand firm against any measures that enable facilities with evident care deficiencies to train the incoming workforce in nursing homes. Nurse aid training should be conducted by facilities with a proven track record of high-quality care, ensuring exceptional education for future healthcare workers and residents' well-being. I urge my colleagues to uphold the integrity of our healthcare workforce and oppose H.R. 3227 and the AINS. Would anybody like the balance of my time? Okay, seeing none, I yield back.
Gentleman yields back. Any further discussion on the amendment? Anyone from the Republican side? Seeing none. The gentlelady from Delaware is recognized for 5 minutes for the amendment.
Mr. Chair, I move to strike the last word. Mr. Chairman, as we are considering legislation at this markup to address the nursing workforce shortage, I'm hopeful that the chairman will consider my own bill, H.R. 2411, the National Nursing Workforce Center Act, in the remaining months of this Congress. Almost exactly a year ago, I withdrew my bill offered as an amendment after the chairman committed to working with me to find a path forward on this important legislation, and I appreciate the chair's work with me on this bill. While we still haven't found the path forward, I know that there is still time remaining to get this bill across the finish line. Over 100,000 registered nurses have left the workforce due to pandemic-related burnout, and almost 1/5 of the more than 4.5 million licensed nurses in the United States intend to leave before 2027. H.R. 2411 is a bipartisan and bicameral effort that I am leading with Congresswoman Young Kim, which works to strengthen the nursing workforce and arms states with the tools that they need to implement solutions based on local conditions. Specifically, it would establish a national nursing workforce center under HRSA and create a pilot program to support state-based nursing workforce centers that carry out research, planning, and programs to address nursing workforce shortages. The U.S. has experienced cyclical nursing workforce challenges for decades, but none as pronounced as today's difficulties. Based on the current state of the nursing workforce in this country, I believe we need a common sense strategy that centralizes the study and development of nursing workforce practice and policy and better supports local entities in addressing state-specific nursing workforce challenges. I believe that this is the most effective path forward to solve this crisis affecting both our workforce and patients. And I'm hopeful that we can work closely to successfully pass the National Nursing Workforce Center Act. Thank you, and I yield back.
Thank you. The gentlelady yields back. Any further discussion? Seeing no discussion on the amendment, if there's no further discussion of the amendment, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All those opposed, nay. The ayes have it, and the amendment is agreed to. On the amendment on the bill, right? Okay. The question, no further discussion on the bill. The question now occurs on forwarding H.R. 3227 as amended to the full committee. There has been a roll call asked for, and the clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess. Latta. Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu. Eshu votes no. Sarbanes. Sarbanes votes no. Cardenas. Cardenas votes no. Ruiz. Ruiz votes no. Dingell. Dingell votes no. Custer. Custer votes no. Kelly. Barragan. Barragan votes no. Blow Rochester. Rochester votes no. Craig? Craig votes no. Schreier? Schreier votes no. Trahan? Pallone? Pallone votes no. Chair Rogers? Chair Rogers votes aye.
Enter the roll call. Seeing none, the clerk will report the result. Oh, and how was Kelly recorded? I'm sorry.
Ms. Kelly is not recorded. No. Kelly votes no.
Seeing no others are seeking to record their vote, the clerk will report.
Chair Guthrie, on that vote, there were 13 ayes and 12 noes.
With 13 ayes and 12 noes, the bill is agreed to. The chair now calls up H.R. 468 and asks the clerk to report.
H.R. 468, a bill to amend Title 11 of the Social Security Act to extend beyond the COVID-19 emergency period with certain modifications, the emergency declaration blanket waiver relating to training and certification of nurse
Without
aides.
objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? The gentleman from New Jersey is recognized for 5 minutes discussion of the bill.
Thank you, Mr. Chairman. I'm moving to speak in opposition. This bill would undermine decades-long requirements for nurse aid training that were established because of serious concerns about untrained nursing home staff. Enacted in 1987, the Nursing Home Reform Act required that nurse aides within their first 4 months of employment complete 75 hours of training and pass a competency test to work in nursing homes. But H.R. 468 would essentially rescind those requirements, allowing nursing homes to employ untrained nurses' aides, in my opinion. Proponents of this bill claim that unwinding these important protections would help to solve our workforce shortages, but to what end? Filling our nursing homes with staff who are inadequately equipped for the job is not only a disservice to the residents who rely on their care, but also to the qualified trained nurse aides who deserve to work in safe and appropriately staffed settings. We know from experience how loosening these requirements plays out. During the height of the COVID-19 public health emergency, nurse aid training requirements were temporarily waived. As a result, many nursing homes hired individuals without adequate training. In many cases, these aides completed as little training as an 8-hour online course. And while this may have been necessary during COVID, this cannot and should not be the status quo for our nation's seniors. It's just not good enough. And the Centers for Medicare and Medicaid Services has since rescinded those waivers, and in doing so indicated that on-site surveys revealed significant concerns with resident care, including abuse, weight loss, depression, and pressure ulcers. For example, CMS indicated nurse aides and paid feeding assistants may not have received the necessary training to help identify and prevent weight loss. Now, I couldn't agree more that we should work together on ways to expand the nurse aid workforce and improve training for nurse aides working in nursing homes. But this proposal is penny-wise and pound-foolish, in my opinion. We must address the underlying issues that are keeping qualified nurse training aides from seeking out and maintaining jobs in nursing homes. What they need is not hard to understand. Nurse aides should be treated with respect, paid an adequate wage, provided with benefits, and be able to work in a safe, appropriately staffed work environment. And nurse home residents should receive dignified care from people who have been trained to provide it. So I urge my colleagues to vote no on H.R. 468. And again, thank you, Mr. Chairman. I yield back.
Gentleman yields back. Anyone seeking discussion on the bill? It's another public. The gentleman from California is recognized for 5
I
minutes.
move
on
to
the bill.
strike the last word.
Gentleman's recognized.
We are seeing nursing shortages throughout the country, but this bill is not the answer. H.R. 468 extends the pandemic-era waiver issued by CMS that allowed untrained nurse aides to work in a facility without meeting their state's training and certification requirements. This waiver was rescinded 2 years ago for good reason. While the waiver helped during the pandemic health emergency under the context of a pandemic crisis that overwhelmed providers, it is no longer needed. Allowing untrained or less trained staff to care for some of our community's most vulnerable patients in long-term care facilities jeopardizes quality of care and safety. Understanding the staffing burden our healthcare facilities face in times of crisis and on a day-to-day basis, we know we need to work towards solutions. But one of those solutions is not building up an untrained or less trained workforce that has led to worse health outcomes. Instead, we should look towards solutions like expanding scholarship programs or pipeline nursing programs starting in junior high all the way through nursing school, or better pay as an incentive for people wanting to go into the nursing profession, or loan forgiveness programs and incentives to provide more training in states with documented health workforce shortages. So I oppose this bill. I urge my colleagues to vote no. I encourage this committee to look up these different solutions so that we can actually have positive, safe, constructive solutions in regards to the nursing shortage. And I thank you, and I yield back.
Gentleman yields back. Any further discussion on the bill? The gentlelady from Michigan, you're recognized for 5 minutes on the bill.
Thanks, Mr. Chair. And I move to strike the last word.
Gentlelady's recognized.
Thank you. We can all agree, and I think we're all saying it on both sides, we must urgently expand our long-term care workforce. But we cannot sacrifice nurse training standards and the safety of patients to do so. Many groups, including the AFL-CIO, SEIU, Elder Justice Coalition, Justice in Aging, and Center for Medicare Advocacy, have expressed strong concerns that these bills might undermine the quality of this workforce and threaten the lives of Americans who need their care. We've already heard from both of my other colleagues about why this doesn't work, but I want to make a couple of other points. This bill would also allow time worked by nurse aides to count towards the current 75-hour training requirement, which helps to ensure the health and safety of residents. The current requirements include specialized training in critical areas, such as protecting resident rights, communicating with cognitively impaired residents, providing personal care, and positioning residents. The training is not likely to be provided while they are working for a whole host of reasons, most of them including high staff turnover and inadequate supervision. And actually, according to the CMS, the waiver program may have had a negative impact on the quality of care. Online surveys during the waiver period indicated significant concerns with resident care on infection control, abuse, weight loss, already discussed depression, and pressure ulcers. Further, an Iowa Dispatch article from 2022 documented abuse of residents by untrained workers. Without specialized training, workers are less equipped to identify and prevent these problems. HR 468 may have made sense several years ago. However, we now have clear evidence that the waiver harmed residents. We cannot go back to the days of the pandemic when untrained workers were still expected to provide quality care to residents. I've met with these residents. I've heard their stories. They've cried in my arms. I urge my colleagues to vote no on this bill and yield back the room.
Gentlelady yields back. Anybody seeking recognition on the bill? Seeing none, are there any bipartisan amendments on the bill? Seeing no bipartisan amendments, I have an amendment. There are partisan amendment, or no, I do have an amendment at the desk. Partisan amendment at the desk. Would you clerk report?
Amendment in the nature of a substitute to HR 468, offered by Mr. Guthrie. Strike all after the enacting clause and insert the following.
Without objection, the reading of the amendment is dispensed with, and I'll recognize myself for 5 minutes on the amendment. When I first agreed to carry this bill, we had the pandemic, and then there were waivers, and I know that we were concerned about the quality in our healthcare system and the availability of people to work in our healthcare system. And when I was first discussing this, we knew during COVID there were going to be waivers that were going to need to continue after the COVID emergency pandemic. When we looked at this specific one, that was the question I asked. Are there any instances anybody can point to that people were harmed because they had somebody, a nurse assistant, operating under this waiver. And I didn't receive any of those ideas. As a matter of fact, there's data that shows facilities utilizing nurse aides scored higher in key areas such as depression rates, lower mobility, lower rates of lower mobility, and lower rates of pressure ulcers. And so in order to get the staffing that we don't want untrained workers, and that's not what this bill does, allow untrained workers to continue in the workforce. We've had 2 hearings on workforce shortages. We're all talking about workforce shortages. And now we know the Biden administration has increased the ratios, and we know that nursing homes are just concerned about, are they going to be able to offer care that's affordable because they can't find the workers? Then they're going to have to close their long-term care. So there's a lot of concerns, and we can, and so what this bill does, if you're a certified nurse assistant, you have 4 months to complete all your training and all your testing and evaluation. You gotta remember, these are people who aren't going to college, have 4 years to complete what they're gonna do, and they have, these are people working, they have jobs, they may have a second job, they may have a family. There's a lot that goes on with these people, and we wanna make sure that they have plenty of time to complete their training. So what this does, it extends the training time from 4 months to 12 months. And we also hear reports of backlog just getting evaluations done. So on day one, the same person shows up under the current law as will be under this law. All we're saying is that the training that they have 12 months to complete the training instead of just the 4 months. It does allow for bedside experience to be for the hours needed, and it has flexibilities in testing and evaluation so people can have the opportunity to be tested. Now, we are concerned about any unsafe situation, and what we have, it targets states that have nursing shortages. So once, we're not just creating this program if there's not a problem. States have to certify there's a nursing shortage within their state, then they will qualify this program. And then any facility that has had any instances of patient harm in the last 2 years will not qualify for this. And so we believe that facilities that are operating in good faith, operating good programs, can train their certified nurse assistants and do it within 12 years instead of 4 months, because within the first 4 months, it's the same person working we're just allowing them to have another 8 months to complete their certification. So if the concern is that we're putting in people that'll be harmful to the residents, you should be harmed about giving them even 4 months. They should show up with full certification if that's the concern of yours. And so I believe this is reasonable. It increases the pipeline, and it will give the opportunity for people to increase, not just the patient, but the individual, to increase their professional status and ability to earn more income within themselves. And so I think this is a reasonable bill to address a problem we all know exists as a workforce pipeline shortage. And I will yield back, and if anybody wants discussion on the amendment, I'll recognize. Is there any further discussion? Seeing none, the vote will occur. If there's no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All those opposed, nay. No. The ayes have it, and the amendment is agreed to. You want a roll call for the full bill? Right. Are there any other discussion on the bill? Seeing none, the question now occurs on forwarding H.R. 468 as amended to the full committee. A roll call has been requested, and the clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess.
Votes aye.
Burgess votes aye. Latta.
Aye.
Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu.
No.
Eshu votes no. Sarbanes. Sarbanes votes no. Cardenas. Cardenas votes no. Ruiz. Ruiz votes no. Dingell. Dingell votes no. Custer. Kelly. Barragan. Blunt Rochester. Craig. Schreier. Schreier votes no. Trahan. Pallone. Pallone votes no. Chair Rogers. Chair Rogers votes aye.
Anyone who's not answered the roll? Has Ms. Kelly recorded?
Ms. Kelly is not recorded. Kelly votes no.
Anyone else? Anyone seeking to be recorded? Seeing no other members seeking to be recorded, the clerk will report.
Chair Guthrie, on that vote, there were 14 ayes and 8 noes.
14 ayes and how many nays?
8.
The aye, so out of 14 ayes and 8 nays, the ayes have it and the bill is agreed to. The chair calls up HR 3433 and asks the clerk to report.
H.R. 3433, a bill to amend the Federal Food, Drug, and Cosmetic Act with respect to molecularly targeted practice.
Without objection, the
Pediatric.
first reading of the bill is dispensed with and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? Seeing none, are there any bipartisan amendments? Seeing none, are there any other amendments? A bipartisan, a gentleman from Florida is recognized to discuss his amendment. Wait, the report.
Thank you.
You have an amendment at the desk?
Yes, I do. It's HR 3433, and I do have an amendment at the desk. So an amendment to HR 3433. I don't have the number of the
The
amendment.
clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 3433, offered by Mr. Bilirakis.
Without objection, the reading of the amendment is dispensed with, and the gentleman from Florida is recognized for 5 minutes in support of his amendment.
Thank you. I appreciate it very much, Mr. Chair. I'm proud to offer the substitute amendment to HR 3433, the Give Kids a Chance Act, to speak in favor and ask all my colleagues to support this amendment and the underlying bill. This legislation will help provide children with new access to clinical trials and therapies for pediatric cancers. Currently, the FDA can only direct pediatric cancer trials and studies for single drugs, and children with relapsed cancer are rarely cured by one-drug treatments because their cancers are often too advanced. Combination therapies are successfully being applied to adult populations, but not always for kids, and that's unfair. The Give Kids a Chance Act will help provide a pathway for pediatric studies of combination therapies for children afflicted with cancer in cases where the second drug is FDA approved and owned by that particular company. Additionally, my substitute amendment includes provisions from our bipartisan bill with Representative McCall, Eshoo, Trahan, Barragan, and Burgess, H.R. 7384, the Creating Hope Reauthorization Act. This legislation extends the Rare Pediatric Priority Review Voucher Program, which provides critical incentives for companies to invest in research and development and ultimately develop new treatments for pediatric rare cancers. Almost 50% of patients living with rare diseases are children, unfortunately. So offering this additional incentive to provide fast-track review of an application upon approval of a successful pediatric rare disease treatment has proven successful since this program started in 2012. In fact, 39 rare pediatric diseases have received treatment that were spurred by a priority review voucher award, the vast majority of which had no previous FDA-approved therapy before the program's inception. This includes diseases such as Duchenne's muscular dystrophy, Friedreich's ataxia, Rett syndrome, and sickle cell disease, all of which can be life-threatening conditions. It's amazing the progress we've made, but we need to do more. In our legislative hearing, we heard from Crystal Davis, who advocated on behalf of the rare disease patient community and told a story about her son, Hunter, and his journey with spinal muscular atrophy. Without the additional PRV, the Priority Review Voucher incentive, I worry that the treatments like that one that he received wouldn't have ultimately come into the market. Furthermore, recently, the National Organization for Rare Disease Disorders, or NORD, released a white paper showing the effectiveness of the rare pediatric PRV program, which has increased over time and led to more FDA-approved treatments as a result. The PRV program has been proven to work and has ultimately been a difference maker in a treatment getting approved for the rare disease community. So my amendment will ensure that this critical program continues beyond the current sunset date of September 30th of this year and adopts technical assistance feedback provided by the FDA to streamline the application approval deadline to one date of September 30th, 2030. I think it makes a lot of sense. Time is of the essence, though. We got to get this bill passed. This alleviates concerns from the agency that the two-phase structure led to a surge in applications before the deadline, and instead ensures that we prevent disruptions through a single date and 6 years. It makes sense. This extension helps provide certainty for both the agency and the industry. I think NORD, I really thank them, and the Every Life Foundation, and over 100 other patient groups that have endorsed this policy, and I urge my colleagues to support it. And in fact, the last time we reauthorized the PRV program in this committee, it passed out unanimously. I hope we can do that today. Lastly, my amendment incorporates the bipartisan bill I co-lead with Representative Matsui, the RARE Act, which will provide a technical fix to ensure regulatory certainty for rare disease drug development and eliminate legal ambiguity by codifying the interpretation of orphan drug exclusivity to be based on the indication approved by the FDA, rather than on the entire designation or disease population. Again, that makes a lot of sense. Rare disease is not a rare problem, as you know, and it affects over 30 million patients nationwide. I hope my colleagues will do the right thing by the rare disease community and our children, of course, by supporting the AINS package. And I yield back the balance.
Gentleman yields back.
you.
Is there any further discussion on the amendment? The gentlelady from California is recognized for 5 minutes on the amendment.
Thank you, Mr. Chairman. I move to strike the last word
Gentlelady's recognized.
and speak on the amendment in the nature of a substitute. First, I want to thank Congressman Bill Arakis for offering the amendment and for his long history of support for people with rare diseases as the co-chair of the Rare Disease Caucus. I'm proud to say that I worked with your father in 2003 to pass the original bill that required pediatric studies in drugs, and I look forward to continuing that legacy with you. It pains me to say this, but I can't support the AINS today unless my amendment is accepted. But I pledge to continue working with you, Mr. Bilirakis, and colleagues on both sides of the aisle to get to a very important bipartisan solution. The AINS does have several important pieces of legislation included in it. First, the Give Kids a Chance Act directs drug companies to conduct pediatric studies of combinations of cancer drugs and therapies. Cutting-edge cancer treatments involve a combination of drugs, and kids deserve to benefit from that scientific advancement. I'm proud to have introduced this legislation with Congressman McCall of Texas. Second, the RARE Act, introduced by Representatives Matsui and Bilirakis, clarifies existing law so that orphan drug exclusivity only applies for the specific approved use of rare disease drugs. And this bill preserves important orphan drug incentives. Third, the Creating Hope Reauthorization Act awards drug makers with valuable vouchers for marketing a treatment for a rare pediatric disease. The AINS today leaves out another critical bill that Representative McCall and I introduced as part of our package to help children with rare diseases, the Innovation in Pediatric Drugs Act. This legislation closes the loophole that allows more than 1/4 of all rare disease medications on the market today to have no studies in it for children. This legislation is an important counterweight to the pediatric voucher program, which is only for diseases that primarily impact children. When a rare disease affects both children and adults, the drug company will often get a treatment for the disease approved for adults and not study it in children. Children who suffer from rare diseases are therefore left behind. Doctors, pharmacists, and parents are cutting pills and mixing medicines, hoping the children under their care receive a safe and effective dose. This legislation would require drug companies that successfully market a rare disease treatment to test it in children with the same disease. Pediatric studies are usually required after a drug is already on the market. When pediatric studies are late, and FDA has found that many required pediatric studies are more than 10 years late, FDA's only recourse is to take the drug off the market. This legislation allows the FDA to enforce pediatric studies the same way it enforces drug studies. We should build on the longstanding strategy of our essentially carrot and stick approach to pediatric drug development. The aims offered by Congress Bilirakis unfortunately doesn't maintain that legacy, and it impacts children with rare diseases and also impact adults. So I offer this rather long but important explanation to all of the members because undoubtedly every single member here wants to improve remedies for children. And what was left out, if it can be added in, which I believe is a very important addition, we're going to have, I think, the most strengthful package for pediatric drug use in our country. So with that, Mr. Chairman, I yield back.
The gentlelady yields back. Is there any further discussion on the amendment? The gentleman from Pennsylvania is recognized for 5 minutes to discuss the amendment.
Mr. Chairman, I move to strike the last word and speak.
The gentleman's recognized.
Thank you, Mr. Chairman. Today, I'm pleased that we are considering H.R. 7384, the Creating Hope Reauthorization Act, that will reauthorize the Rare Pediatric Disease Priority Review Voucher Program until fiscal year 2029. The ability of companies to sell or redeem a new drug or biologic for priority review is critical to a robust pipeline of treatments for pediatric patients. The vouchers from this program provide a strong incentive to develop drugs with rare pediatric disease designations. Since the program's inception, these vouchers have been awarded across 39 pediatric diseases, only 3 of which had any FDA-approved treatments prior to the program. Reauthorization of this program is critical to support innovation in the rare pediatric disease space and address an unmet need for children who suffer from these serious conditions. Innovation is a core pillar of American medicine, and our children deserve nothing but the best in terms of new life-saving treatments, and it is incumbent on us as legislators to ensure that the proper incentives are in place for this to occur. The other bills included in this aims will also help lower costs and increase pediatric patients where there otherwise might not be the necessary hope. I urge my colleagues to support the aims, and I yield back the balance of my time.
The gentleman yields back. Is there further discussion? Excuse me, the ranking member is recognized for 5 minutes on the amendment.
Thank you, Mr. Chairman. I move to strike the last word and speak in opposition to the bill. Although I like the substance of the underlying bill, I can't support the aims or the underlying bill because of the way my Republican colleagues have decided to package these bills today. and their refusal to work with us on a bipartisan basis. The bills do not reflect this committee's responsibility to ensure an appropriate balance between holding drug sponsors accountable to patients and providing drug companies with billions of dollars in financial incentives. So I urge my colleagues to oppose this bill and to support Representative Eshu's amendment to improve the bill and ensure that manufacturers are doing their share to improve the pipeline of pediatric drugs and carry out their responsibilities to pediatric patients. I'd like to start by reiterating that I do support the underlying bill, and it's strong and it's bipartisan, and with the help of our efforts, it will lead to new treatments for more advanced forms of pediatric cancer. Additionally, I'm also supportive of H.R. 7383, the Retaining Access and Restoring Exclusivity, or RARE Act, which the majority intends to add by amendment to H.R. 3433, obviously. And this bipartisan legislation would codify FDA's long-held treatment of orphan drug exclusivity, which has always said that the exclusivity extends to a particular indication. But a recent court case, which held otherwise, would essentially overturn decades of precedent of interpreting the Orphan Drug Act, and this could lead to products coming off the market and blocking innovation for orphan drugs. However, the overall package I can't support because, unfortunately, the majority refused to work with us to strike a balanced approach to the reauthorization of the Pediatric Priority Review Voucher Program. In 2020, when this committee last reauthorized the Pediatric Review Voucher Program, I said that we would need to keep a critical eye on the program to ensure it did not overly tax FDA's resources and that it provides the incentives it promised. Unfortunately, we still have not seen the compelling concrete evidence that this program is functioning how Congress intended it to. At our February hearing, we heard from Dr. Aaron Kesselheim from Harvard that these vouchers do not help start new trials or bring new innovative drugs to market in any field, much less for rare pediatric diseases. Further, they are disruptive to FDA's review processes and can delay other important therapies from being made available to patients. So I'm willing nonetheless to work with my colleagues across the aisle to reauthorize this program and make it work better. And we've tried to meet them in the middle, but unfortunately, the Republicans have refused to meet us halfway or even part of the way, in my opinion. Instead, they are insisting that we reauthorize the Rare Pediatric Disease PRV program without any requirements to also hold these companies accountable to the pediatric patients the program was first created to help. And they have been unwilling to work with us to incorporate, as we've said, Representative Eshu's bill, H.R. 6664, the Innovation in Pediatric Drugs Act, which would strike the right balance by requiring drugs for rare diseases to be studied in children. So these priority review vouchers are worth hundreds of millions, possibly billions of dollars to the drug companies that benefit from them, and yet they refuse to conduct clinical trials in pediatric populations for rare disease drugs. And when they refuse to complete clinical trials in pediatric patients for their approved drugs, we can't hold them accountable. I mean, that is simply not acceptable to me. So I think the committee should be considering Ms. Eshu's bill today because it would provide a holistic approach that not only rewards drug developers, but also holds them accountable to pediatric patients and strengthens the pediatric drug pipeline. And that's why I strongly urge support for Ms. Eshu's amendment today, which would add the Innovation in Pediatric Drugs Act to the bill. In previous reauthorizations of the Rare Pediatric Disease PRV, Democrats and Republicans worked across the aisle to ensure Congress balanced responsibility of drug sponsors with incentives to ensure the program provided a full approach to bring products to patients. Unfortunately, the legislation that Republicans have brought to the markup today is not a reflection of the bipartisan work this committee has done in the past. So I strongly urge my colleagues to vote no on this bill, and I urge my colleagues to support Representative Eshu's amendment to the bill. And with that, I yield back, Mr. Chairman.
The gentleman yields back. Is there any further discussion on the Ains? Seeing none, is there an amendment to the Ains to be offered, gentlelady from California?
Thank you, Mr. Chairman. I have, I wanted to speak to the amendment. It preserves the...
Let me get the clerk to...
Oh, I'm sorry.
report.
Okay.
Will the clerk report the amendment?
Amendment to
By
the
the lady
amendment.
from California?
Amendment to the amendment in the nature of a substitute to H.R. 3433.
Without objection, reading the amendment is dispensed with, and the gentlelady is recognized for 5 minutes in discussion of her amendment.
Thank you, Mr. Chairman. My amendment preserves the delicate flexibilities that companies need to get drugs to market and reap the reward of their work of creating new pediatric products, all without hampering their ability to innovate. It includes nearly the same legislation as Mr. Bilirakis' aims, but also includes bipartisan legislation. I want to underscore that. It's bipartisan legislation to require studies for children with a rare disease. The legislation is moderate and it's flexible because first, it limits the universe of required pediatric studies to only those treatments that would have a meaningful benefit for children. It provides waivers to exempt companies from pediatric studies when a study is impossible or highly impracticable. For example, if a drug can't be studied in certain age cohorts or when a clinical trial is too difficult to enroll children in. And it gives the FDA the same enforcement authority for pediatric studies that we passed last Congress as part of our bipartisan changes to the accelerated approvals pathway. The American Academy of Pediatrics, the Leukemia and Lymphoma Society, the Children's Hospital Association, Children's Cancer Cause, the National Organization for Rare Disorders, the Alliance for Children Cancer, the Elizabeth Glaser Pediatric AIDS Foundation, St. Jude Children's Research Hospital, and the Coalition Against Childhood Cancer have all endorsed the legislation. I'd also like to submit for the record, Mr. Chairman, a letter of support for the legislation signed by 41 organizations.
Without objections, so ordered.
And finally, I want to address the length of the reauthorization for the priority review voucher program. In Representative Bilirakis' amendment, the length of the reauthorization is 6 years. In my amendment, it's for 3 years, so that it aligns with the user fee schedule, ensuring the program is more easily reauthorized because it'll be paired with must-pass legislation. In past reauthorizations, we've always done 4 years. So I'll work with you to settle on a number of years between now and the full committee consideration to really get, to get this in place. It's just so important for the kids. So I thank you, Mr. Chairman, and I yield back.
Gentlelady yields back, and the chair will now recognize myself on the amendment. I want to thank my good friend, Ranking Member Eshoo, for all of her work that she's done. And your legacy in this Congress will, number one, I think, well, I don't know of all of them, but I can tell you one that I know will be how you have increased the rapidity of getting drugs to the marketplace so that people can benefit from it, so people can benefit sooner. I know some people like to quote a Harvard law professor about this doesn't really matter how quickly we move forward. It's better to wait, but I will tell you there are families that are indifferent when they are suffering from this. So I want to thank you for all the work. In the prior passage of the first laws incentivizing pediatric studies, more than 80% of approved drugs had no pediatric-specific labeling information. Now, owing to a careful balance between the Best Pharmaceuticals for Children Act, BPCA, the Pediatric Research Equity Act, PREA, and the FDA, has over 50 drugs with over 70 indications for the treatment of pediatric cancers alone. We all share the same goal to get the best possible information and treatment to the kids that need it. That being said, there's a philosophical difference on how we get there, and the difference in mandates and penalties. How would that improve accountability and expecting this outcome ignores when so-called noncompliance occurs? Instead, the threat of more stringent penalties for PREA violations, when coupled with the elimination of orphan exemption, would continue to erode needed investment in drug development for rare diseases. Instead, we must facilitate and incentivize innovation, especially where market incentives may not exist, such as rare diseases that are already difficult to study given their rarity, especially in children that we all want to protect. Unfortunately, the amendment does not grapple with the meaningful headwinds to successful pediatric drug development, particularly the significant challenges of enrolling an adequate number of patients in generating sufficient data regarding the drug's use in a pediatric population. Under this amendment, drugs for rare diseases that the Secretary determines could represent a meaningful therapeutic benefit will be subjected to the first time to requirements to study kids. That sounds simple, but companies will have to wait for a guidance and a waiver list to see how this threshold will be applied in practice. And this is subjective and creates significant uncertainty as pre-requirements can apply to any number of drugs for rare diseases. Just to illustrate, in 2023, CEDAR approved 55 novel drugs, over 50% which were orphan designated. CBER approved 12 orphan designations, designated new BLAs. Will each of these drugs require a waiver, and for what age ranges? Will a drug for neonates need a waiver for older children? On the other hand, will a manufacturer require a waiver for product that isn't available until symptoms manifest in older children? These are just some of the outstanding questions that deserve more scrutiny, and given it a significant divergence from the status quo. Not to mention, this proposed change takes place in the context of systematic incentives that have dropped under the Biden administration. As I understand, the FDA released dual controversial draft guidances in May 2023, one of which that limited the carrot of the BPCA. Moreover, the drug's been chosen as soon as 7 years after the FDA approval for the new drug control in the IRA. I fear that labels for children will be fewer over the next decade. According to a recent study, the average time after original approval for a pediatric indication approval was 8.9 years, and 10 of the 18 were approved 7 years or more following original approval. Finally, the bill presents process challenges that cannot be overlooked because it increases authorization levels with no offset in other spending programs. And we've worked to produce offsets as we move forward throughout the full committee. So while I appreciate the effort and the hard work and the goals, and grateful for the work on the BPCA and PREA that has such amazing impact, I think that this amendment takes the wrong approach, and I recommend a no vote. I will. Anybody else seeking discussion on the amendment? I yield back. Anybody else seeking discussion? Oh, I have a minute left. You would like to? I'll yield to the gentleman from California.
Thank you,
Before I yield
Mr. Chairman. In listening hard to what you just said, these are all technical issues, and I stand ready to work with you to resolve them because the underlying purpose of the legislation is just too important to end up on a scrap pile of things unattended to, and we're all committed to the children. So I'm 1,000% committed to work out these technical issues that you just outlined.
Thank you, and the 100%, I'll stand by that. When I said you were my friend, that's 100% accurate, and when I said that you are a known leader in getting getting drugs to the pharmaceuticals, the marketplace quicker, especially for children, that's been your it will be your legacy in my view. I'll yield back, and the chair recognizes the gentleman from Texas for 5 minutes.
Mr. Chairman, I just had a question, but it actually was just addressed by Ms. Eshoo. I do not want to vote against this amendment. At the same time, I hope that the committee, I was here in 2003 as well, and I think this is an extremely important concept, and I hope, like Representative Eshoo, I do not want to see it discarded on the heap of amendments that didn't make it. I think it is worthy of continued study and continued work, so I'm grateful for her comments that she's willing to do that, and I hope that we can see our way forward in the future to do the same.
Thank you. Thank you for those comments. Gentleman yields back. Any further discussion? Any discussion on without further discussion, the vote occurs on the amendment. Oh, excuse me, the gentleman from Florida, seek recognition on the amendment?
Yeah, thank you very much, Mr. Chairman. I appreciate it very much. As everyone knows, I have a ton of respect for the ranking member, Eshoo, and I appreciate her bringing up my father's name as well. I didn't realize he authorized the bill initially in 2003. It must be in our DNA because we have the same interests. Even though we don't talk policy, we talk baseball and family anymore. But we appreciate it very much. I'm concerned, though, that the amendment she is offering as drafted, and of course I want to work with you on these issues, undercuts the bipartisan product we have before us and could ultimately harm the rare disease patient community by delaying or preventing access to new treatment options. The amendment would extend PRV program for 3 years less than the bipartisan introduced legislation and the manager's amendment. But on that issue, of course, I'm willing to work with you. But going through 2027 instead of 2030, I think 2027 is the wrong date. Given the development timeliness for rare disease treatments, this is not a meaningful extension, in my opinion. Patient groups have resoundingly supported a long-term PRV reauthorization, and this would go against that policy in a way that I fear will hurt the pipeline for rare disease treatments and cures. It would also create additional uncertainty, the amendment would, to the amendment, for developers already facing significant headwinds. It grants the agency enormous discretion and red tape. The treatments the Secretary designates would be subject to burdensome requirements to get rare disease drugs approved by requiring pediatric studies, and many of whom are already working with pediatric populations and diseases. It doubles the size of the NIH program to study older drugs in children without providing any sort of offset through decreases of funded authorizations in other areas, and does so well before the PBCA program expires. Lastly, it would subject companies to significant enforcement penalties who do not conduct their pediatric studies, even though when it may not be feasible to conduct these studies in the time required, instead giving FDA more authority to decide whether to issue waivers. In particular, I have concerns with a shorter PRV reauthorization, as I said, increasing requirements on rare disease companies at a time when incentives have dramatically decreased, and doubling an authorization without the necessary offset, which jeopardizes consideration on the floor. If you would be willing, of course, to withdraw. Otherwise, if you don't withdraw and this goes down, of course, I'm willing to work with you. But if you do withdraw the amendment, I think we can make progress on including a provision holding drug makers accountable for not following the provisions of the law or conducting their studies, and working to potentially add this, again, this particular year improvement to the full committee. I also appreciate the GAO study within the amendment and believe that we could be a good starting point to better identify and address the problem she is a great member is describing by the time we get to our next Prescription Drug User Fee Act reauthorization process. But I don't want to jeopardize the bill. So unfortunately, I cannot support this amendment at this particular time in its current form, and I ask my colleagues to vote no on this particular amendment. Thank you very much, and I yield back the balance of my time.
Gentleman yields back. Any further discussion on the amendment? You want a roll call vote? If no further discussion on the amendment, a vote will occur, and there has been a roll call vote requested, and the clerk will call the roll.
Guthrie.
No?
Guthrie votes no. Burgess.
Pass.
Burgess passes. Latta. No. Latta votes no. Griffith. No. Griffith votes no. Bilrakis. Bilrakis votes no. Bouchon. No. Bouchon votes no. Hudson. Carter. Carter votes no. Dunn. Dunn votes no. Pence. Pence votes no. Crenshaw. Crenshaw votes no. Joyce. Joyce votes no. Balderson. Balderson votes no. Harshbarger. Miller Meeks. Miller Meeks votes no. Obernolte. Obernolte votes no. Eshu. Eshu votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Kelly votes aye. Barragan. Barragan votes aye. Blount Rochester. Blount Rochester votes aye. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Pallone. Aye. Pallone votes aye. Chair Rogers. Chair Rogers votes no.
Anyone else that can answer the roll call? Seeing none, the clerk will report.
Chair Guthrie, on that vote, there were 12 ayes, 14 noes, and 1 pass.
With 12 ayes, 14 noes, and 1 pass, the amendment is not agreed to. Are there further amendments? The question now occurs on adopting the amendment in the nature of a substitute. I got this here. If there are no further discussion of the amendment of the nature of a substitute, all those in favor vote aye. Aye. Other votes nay. The ayes have it, and the amendment is agreed to. The question now occurs on forwarding H.R. 3433 as amended to the full committee. All those in favor, the gentleman requests a roll call vote. The clerk will call the roll.
Guthrie?
Aye.
Guthrie votes aye. Burgess?
Votes aye.
Burgess votes aye. Latta?
Aye.
Latta votes aye. Griffith? Griffith votes aye. Bilirakis? Bilirakis votes aye. Bouchon? Bouchon votes aye. Hudson? Carter? Carter votes aye. Dunn? Dunn votes aye. Pence? Pence votes aye. Crenshaw? Crenshaw votes aye. Joyce? Joyce votes aye. Balderson? Balderson votes aye. Harshbarger? Miller Meeks? Obernolte? Obernolte votes aye. Pallone? Pallone votes no. Eshu? No. Eshu votes no. Sarbanes? Sarbanes votes no. Cardenas? Cardenas votes no. Ruiz? Ruiz votes no. Dingell? Dingell votes no. Custer? Custer votes no. Kelly? Barragan? Kelly votes no. Barragan votes aye. Blount Rochester? Blount Rochester votes no. Craig? Craig votes no. Schreier? Schreier votes no. Trahan? Chair Rogers? Chair Rogers votes aye. Ms. Miller Meeks is not recorded. Miller Meeks votes aye.
Anyone else seeking to answer the roll call? Seeing none, the clerk will report.
Chair Guthrie, on that vote, there were 16 ayes and 11 noes.
With 16 ayes and 11 noes, the bill is agreed to. The chair calls up H.R. 7188 and asks the clerk to report.
H.R. 7188, a bill to require the Secretary of Health and Human Services to conduct a national evidence.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? The you want to do the amendment, right? The gentlelady seeks recognition on the bill. The gentlelady from Michigan is recognized.
Thank you, Mr. Chairman. I'm very grateful that the Shandra Eisenga Human Cell and Tissue Product Safety Act is included as part of today's markup. I'm leading this bipartisan bill alongside my friend and colleague from Michigan, Representative John Molinar. Last summer, I was contacted by the medical director of the Washtenaw County Tuberculosis Clinic, who was treating a patient, Shandra Eisenga, for a severe post-surgical tuberculosis infection. She was actually Representative Molinar's constituent, but she was being treated at the University of Michigan, which is in my district. After a month battling a severe TB infection in the intensive care unit, Shandra unfortunately died. Chandra's physician was particularly alarmed since he realized that she had recently received a bone graft that was manufactured by Aziyo Biologic, a company with a troubling history with contaminated bone grafts. In 2021, units of contaminated bone graft manufactured by Aziyo Biologic was implanted into 113 patients. 87 of them developed TB infections, and 8 died. Since Chandra's passing, it's been discovered that her death was indeed linked to the contaminated bone graft material produced by Aziyo Biologic. She was one of 36 patients who received material from the contaminated lot, and as of today, this latest outbreak is linked to the deaths of 2 patients, including Shandra. I've been working closely with the FDA and the Centers for Disease Control and Prevention to better understand the manufacture and regulation of human cells, tissues, or cellular or tissue-based products, HCTPs for short, to ensure that they can be used to improve patient outcomes, not harm them. Most of you know that a few years ago when I had the problem with my jaw, I had a bone graft, a serious one into my jaw, and I can personally say no one spelled out the potential risks. And that's why these pieces of legislation are so important. Taken together, they will take steps to ensure patients better understand the risks associated with bone graft materials, but even more important, improve the testing and screening of tuberculosis in donor materials that are used in medical procedures. I thank the subcommittee chair and the ranking member for including this important piece of legislation. I know my colleague, Rep. Molinar, is very grateful too. He's been a great bipartisan partner. We owe it to Shandra, her family, and every other patient who's been affected by contaminated bone grafts to ensure that we're doing everything we can to prevent these unnecessary tragedies from happening again. I urge my colleagues to vote yes on this bill, and I yield back the remainder of my time.
The gentlelady yields back. Any further discussion on the bill? Seeing none, the gentleman from Texas is recognized for an amendment.
Mr. Chairman, I have an amendment at the desk.
The clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 7188, offered by Mr. Crenshaw.
Without objection, the reading of the amendment is dispensed with, and the gentleman from Texas is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Chairman. I'm offering this amendment in the nature of the substitute for the Shandra Eisenga Human Cell and Tissue Product Safety Act, sponsored by Representatives Molinar and Dingell. I want to be clear, I support the underlying bill, and this AINS would keep that bill intact and add an additional legislation as well, which I'm going to talk about now. The underlying bill, as my colleague just explained, is for Shandra, who tragically passed away from tuberculosis last year, becoming sick after a contaminated bone graft during surgery, something that no patient should ever have to go through. These cell and tissue products can save lives, but we have to ensure that the standards are clear, that providers and patients are educated on the risks and the benefits. And this bill does a couple of key things. Educates patients, providers, and industry. It also ensures that the FDA has the most up-to-date guidance so that industry can properly screen for pathogens like tuberculosis. Second, the bill includes important bipartisan policies that I worked on with Representative Barragan, which I really appreciate her bipartisan support on this. These are policies that are going to encourage innovation in regenerative medicine. So you might ask, what is that? What is regenerative medicine? Regenerative medicine is when we use the human body to heal disease. And in some cases, we're quite literally using a patient's own body, their own cells, to cure disease. It's one of the great medical miracles of our time, but to succeed, we've got to make sure that the regulatory environment encourages innovation, because these are complex therapies and there's a lot of emerging science. So what this bill does, it encourages more FDA communication with innovators. And this bill also moves us closer to a new pathway so that we are not applying a one-size-fits-all regulation to some of the most life-changing, life-saving cell therapies. This is something I plan to continue to work on with the FDA, because the wrong regulation can quite literally mean the difference between innovation that saves lives and patients that are left out in the cold with no options. This amendment will advance safety and innovation, and I ask everyone to vote in support of it. Thank you, and I yield back.
Gentleman yields back. Is there any other further discussion
Mr. Chairman,
on the amendment? Mr. Sarbanes recognized.
move to strike the last word.
Recognized 5 minutes.
I'd like to speak in support of the AINS to H.R. 7188, the Shandra Eisenga Human Cell and Tissue Product Safety Act. I want to note that I know I'm channeling the perspective of Ranking Member Pallone as well. This language could improve human cell, tissue, and cellular and tissue-based product safety through increased awareness of scientific and regulatory efforts by the FDA's Center for Biologics Evaluation and Research to oversee these products. I'm glad that we're working on a bipartisan basis to get this legislation to a place that balances providing clarity to industry while also preventing the serious harms that we heard our colleague Ms. Dingell speak about, including the death of Shandra Eisenga, the bill's namesake. I want to note that, unfortunately, this version still does not include the language that would provide FDA with additional enforcement levers to prevent bad actors from marketing products that could lead to death or serious injury from an outbreak. There are currently few meaningful repercussions in the human cell and tissue products industry. Providing the agency with additional enforcement tools would allow them to more quickly and effectively protect the public, and this would also encourage responsible manufacturers to continue to develop and license products where the scientific evidence supports the product's safety, purity, and potency. Mr. Chair, I know that Democrat and Republican staff have agreed to make changes before this moves to the full committee. I appreciate that. I know that Ranking Member Pallone also appreciates that commitment to keep working to improve this legislation before we do move it to the full committee. And given that commitment and our bipartisan efforts, I'll be voting in favor of this proposal. I know that Ranking Member Pallone is supportive as well, and with that, I thank you and I yield back.
Gentleman yields back. Any further discussion on the amendment? Recognize Ms. Dingell.
I just want to say I too support but do hope we will continue to talk so that we are all working together to keep this from happening to anybody else ever again.
Gentleman yields back. Any other discussion on the amendment? If there's no further discussion, the vote occurs on the amendment. All those in favor signify by saying aye. Aye. All those opposed, say nay. The ayes have it, and the amendment is agreed to. The vote now occurs on H.R. 7188, and a roll call vote has been requested. The clerk will call the roll.
Guthrie? Aye. Guthrie votes aye. Burgess? Aye. Burgess votes aye. Latta?
Aye.
Latta votes aye. Griffith? Aye. Griffith votes aye. Bilrakis? Aye. Bilrakis votes aye. Bouchon? Aye. Bouchon votes aye. Hudson? Carter? Carter votes aye. Dunn? Dunn votes aye. Pence? Pence votes aye. Crenshaw? Crenshaw votes aye. Joyce? Joyce votes aye. Balderson? Balderson votes aye. Harshbarger? Miller Meeks? Obernolte? Obernolte votes aye. Eshu? Eshu votes aye. Sarbanes? Sarbanes votes aye. Cardenas? Cardenas votes aye. Ruiz? Ruiz votes aye. Dingell? Dingell votes aye. Custer? Custer votes aye. Kelly? Kelly votes aye. Bardagan? Bardagan votes aye. Blow Rochester? Blow Rochester votes aye. Craig? Craig votes aye. Schreier? Schreier votes aye. Trahan? Pallone? Pallone votes aye. Chair Rogers? Chair Rogers votes aye.
Any other members looking to be recorded? Seeing none,
Miller Meeks is not recorded. Miller Meeks votes aye.
any other members? Seeing none, the clerk will report.
Chair Bouchon, on that vote, there were 27 ayes and 0 noes.
The ayes have it, and the bill is agreed to. And the Bill 7188 is forwarded to the full committee. Chair calls up H.R. 6020 and asks the clerk to report.
H.R. 6020, a bill to amend the Public Health Service Act to eliminate consideration.
Without objection, the first reading of the bill is dispensed with, and the bill will be open to amendment at any point. So ordered. Does anyone seek recognition on the bill? Mr. Obernolte, recognized.
Mr. Chair, I move to strike the last word.
Recognized for 5 minutes.
Mr. Chairman, thank you for the opportunity to testify in support of my bill, H.R. 6020, the Honoring Our Living Donor Act. I think it's pretty clear that one of the most powerful acts of generosity anyone can perform is the donation of an organ to someone else. And there is a desperate need for those donations. We currently have over 100,000 Americans on the waiting list for an organ transplant. But unfortunately, there are not enough donated organs to go around, not even close. Over 6,000 Americans died last year while still on the waiting list waiting for an organ transplant. And in the last 15 years, there has actually been a 7% decline in the number of living organs that were donated. Unfortunately, during that same period, the waiting list for donations has risen by over 50%, and over 100 Americans are added to that list every single day. In response to that need, several years ago, Congress established the National Living Donor Assistance Center to provide financial assistance to people who are willing to donate an organ. It's no surprise that in addition to the physical disability involved with donation, there is substantial financial commitment involved. The typical living donor has to take at least 2 weeks off of work, sometimes as much as 6 or 8 weeks off of work to be able to donate an organ. So the National Living Donor Assistance Center provides financial assistance to those donors in reimbursing them for lost wages and things like childcare that are required as a result of their donation. Quite sensibly, there is a requirement for an income limitation on this program, and the donor must be at 350% of the poverty level or below. But unfortunately and nonsensically, that income limitation also applies to the recipient of the organ. I think we can all agree that making the income limitation require only to the donor not only makes more sense, but will incentivize more people to be able to afford to be living donor donors and commit this unbelievable act of generosity. So this bill makes that simple change to make the income limitation apply only to the donor of the organ and not the recipient. I think this is a common sense provision. I'd like to thank my Democratic co-chair, Congresswoman Delbene, for leading this piece of legislation with me, and I respectfully urge its adoption. I yield back, Mr. Chairman.
Gentleman yields back. Any further discussion on the bill? Seeing none, are there bipartisan amendments to the bill? Mr. Obernolte.
Mr. Chairman, I have an amendment in the nature of a substitute at the desk.
Clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 6020, offered by Mr. Obernolte. Strike all after the enactment.
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of the amendment.
Mr. Chairman, this amendment in the nature of a substitute makes technical changes to the reporting language in the bill requested by stakeholders. Just common sense, and I urge its adoption. I yield back.
The gentleman yields back. Any further discussion on the amendment? Seeing none, if there's no further discussion, the vote now occurs on the amendment. All those in favor saying aye. All those opposed say no. In my opinion, the ayes have it, and the amendment is agreed to. Are there any other bipartisan amendments to the bill? Any other amendments to the bill? Seeing none, the vote now occurs on passage of the bill. And I don't have the text here. 6020 to forward it to the full committee. A roll call vote. We have to vote. A roll call vote has been requested on reporting the bill as amended to the full committee. The clerk will call the roll.
Guthrie? Aye. Guthrie votes aye. Burgess? Latta?
Aye.
Latta votes aye. Griffith? Griffith votes aye. Bilirakis? Bilirakis votes aye. Bouchon? Bouchon? Bouchon votes aye. Hudson? Carter? Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu. Eshu. Eshu votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Custer. Custer votes aye. Kelly. Kelly votes aye. Barragan. Barragan votes aye. Blount Rochester. Blount Rochester votes aye. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye.
Where are we in the roll call? Where are we in the roll call? Who have not entered the roll call?
Burgess is not recorded. Hudson is not recorded. Crenshaw is not recorded. Harshbarger is not recorded. Dingell is not recorded.
That's all of our, okay. So will anybody else on your side seeking to record? Seeing none, will the clerk report?
Chair Guthrie, on that vote, there were 24 ayes and 0 noes.
With 24 ayes and 0 noes, the bill is agreed to. The chair calls up H.R. 455 and asks the clerk to report.
H.R. 455, a bill to amend the Controlled Substances Act to fix a technical error in the definitions. Be it enacted by the Senate and the House.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? Seeing none, are there any bipartisan amendments? Seeing none, are there any other amendments? His amendment. Ms. Custer, you have an amendment to the bill? Yeah. Did the gentlelady report her amendment? Will it report to? Oh, strike the last word, I'm sorry.
Thank you very
The
much.
lady's recognized for 5 minutes.
Thank you. I'd like to call up an important amendment concerning the Controlled Substances Act, and it's Custer 98.
Amendment to H.R. 455, offered by Ms. Custer of New Hampshire.
Without objection, reading the amendment is dispensed with, and the gentlelady is recognized for 5 minutes in support of her amendment.
Thank you, Mr. Chairman. I understand that this amendment is not germane to this bill, but I'd like to take this opportunity to highlight an important tool to address the addiction and overdose crisis that is about to expire. During the COVID-19 pandemic, the Drug Enforcement Administration allowed providers to prescribe medication-assisted treatment for opioid use disorder remotely. This flexibility allowed more Americans to receive this life-saving treatment that they needed and certainly deserved. Evidence shows that access to medication-assisted treatment via telehealth has been transformative for people with opioid use disorder. Remote access has meant that patients no longer have to worry about transportation, childcare, taking time off from work, or other circumstances that could impact their ability to get to a doctor's office. Just this week, the CDC released data showing overdose deaths fell last year for the first time since the onset of the pandemic. Unfortunately, the flexibility that allows healthcare providers to provide remote care for these patients expires at the end of this year. After proposing and withdrawing a burdensome rule last year, the DEA has yet to indicate that they will allow patients to continue accessing their life-saving medication remotely. This is, quite frankly, unconscionable. People will die as a result of this decision, including people who I love very much. Without action, patients will lose access to their treatment, and at a time when overdose deaths are finally falling, we should make it easier than ever for people who want to get help to get better.
If the DEA won't exercise its authority to allow patients access to telehealth services for opioid use disorder treatment, Congress should pass the TREATS Act. The TREATS Act would allow patients to continue receiving the help they need without the barriers associated with in-person visits. And with that, I will withdraw my amendment and yield back.
Little gentlelady withdraws her amendment. Are there any other amendments on the bill? Any further discussion on the bill? Seeing none, the question now occurs on forwarding HR 455 to the full committee. All those in favor, so we want a roll call vote on. So there'll be a roll call vote, so the clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess. Latta.
Aye.
Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Dunn. Dunn votes aye. Pence. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu.
Aye.
Eshu votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Custer. Custer votes aye. Kelly. Kelly votes aye. Barragan. Barragan votes aye. Blau Rochester. Blau Rochester votes aye. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye. Mr. Pence, you're not recorded. Pence votes aye.
Anyone else seeking to be recorded? Anyone else seeking to vote? Seeing no others present to vote, the chair will ask the clerk to report.
Chair Guthrie, on that vote, there were 24 ayes and 0 noes.
With 24 ayes and 0 nays, the bill is agreed to. The chair calls up HR 7213 and asks the clerk to report.
HR 7213, a bill to amend the Public Health Service Act to enhance
Without
activities.
objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? Or are there any bipartisan amendments? Seeing none, are there any other amendments? And the chair will recognize himself for an amendment. I have an amendment in the nature of a substitute at the desk. Ask the clerk to report.
Amendment in the nature of a substitute to HR 7213.
Without objection, the amendment is dispensed with, and I will recognize myself for 5 minutes, and I appreciate the opportunity to substitute for my good friend from Ohio on this amendment who's worked on this bill and this amendment, my good friend Bob Latta. I'll explain the amendment. I want to speak in support of this amendment. I'm proud to be offering the Ains along with my friend from Ohio, and I'm grateful for all the work done on the bill by the sponsor, Representative Chris Smith. He's been a fierce advocate and leader on these issues for decades. The program and activities authorized under Autism Cares has been the primary driver of autism research, services, training, and monitoring across the federal government. The Ains makes certain improvements to the current program, including ensuring the programs are appropriately channeling resources towards the most impactful forms of research and services, as well as coordinating various programs at NIH, CDC, and HRSA. The bill also continues to train providers in utilizing valid and reliable screening tools to diagnose and provide evidence-based interventions. The goal is to promote early intervention strategies to improve outcomes for individuals with the autism spectrum disorder and other developmental disabilities. Importantly, it takes steps to ensure the public and all individuals with the autism community have an opportunity to engage in and are included in the research process and other activities related to autism spectrum disorder. I'm proud of the work that has been done thus far on this bill and passionate engagement and communication of stakeholders throughout the process. We continue to welcome feedback on the current text and look forward to working as it moves to full committee. as supported this aims and support of the legislation, and I will yield back. Does anyone else speak recognition on the aims? Seeing none, if there's no further discussion, the vote occurs on the amendment in the nature of a substitute. All those in favor shall signify by saying aye. Aye. All opposed, nay. The ayes have it, and the amendment is agreed to. The question now occurs on forwarding H.R. 7213 as amended to the full committee. A roll call has been requested, and the clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess. Latta.
Aye.
Latta votes aye. Griffith. Griffith votes aye. Blaurakis. Blaurakis votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Dunn. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu. Eshu votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Custer. Kelly. Kelly votes aye. Barragan. Barragan votes aye. Blow Rochester. Blow Rochester votes aye. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye.
Anyone seeking to answer the roll call is not, how's Mr. Crenshaw recorded?
Mr. Crenshaw is not recorded. Crenshaw votes aye.
Anyone else? Seeing none, the clerk will report.
Chair Guthrie, on that vote, there were 22 ayes and 0 noes.
With 22 ayes and 0 nays, the bill is agreed to. The chair calls up H.R. 4534 and asks the clerk to report.
H.R. 4534, a bill to require a review of women and lung cancer.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point, so ordered. Are there anyone seek recognition on the bill? Purpose of the gentlelady from Illinois seek recognition?
Mr. Chair, I move to strike the last word.
Gentlelady's recognized.
Thank you, Mr. Chair. My amendment makes some clarifying changes to the underlying bill to better focus the existing collaboration between HHS, the DOD, and the VA on research related to lung cancer in women and underserved communities. The amendment establishes an interagency review to evaluate current research on lung cancer, improve the accessibility of lung cancer preventative services to women, and provide a report to Congress with recommendations to enhance public awareness and prevent activities for lung cancer. During our legislative hearing on the bill in February, we heard testimony from the American Cancer Society that research is needed to determine if there are unique factors for women, especially with respect to lung cancer. The American Cancer Society testimony also noted that despite historically lower smoking rates than men, women are estimated to make over half of all new lung cancer cases and nearly half of all deaths in 2023. Furthermore, women have a slightly higher proportion of lung cancer not attributable to modifiable risk factors like smoking. I believe this amendment and the underlying bill will provide a clearer, comprehensive understanding of the existing research as well as new innovative opportunities to reduce lung cancer mortality, particularly among women. I want to thank the staff of the chair and ranking member for working with me on this language, and I would also like to recognize and thank Rep. Boyle for being our champion of this effort in the House. As chair of the Congressional Black Caucus Health Brain Trust, I will continue to work with my colleagues on both sides of the aisle and the Biden-Harris administration to curb the harmful impacts of tobacco on communities of color and ensure that health equity is at the center of federal public health policy. Thank you, and I yield back.
The gentlelady yields back. I believe the gentlelady also has an amendment at the desk. I'm sorry, I didn't call the amendment up. Does the gentlelady have an amendment at the desk? The clerk will report.
Amendment in the nature of a substitute to H.R. 4534, offered by Ms. Kelly.
Without objection, the reading of the amendment is dispensed with. The gentlelady is recognized for 5 minutes on the amendment. I think you just explained the amendment.
Right, I just explained that.
Thank you. So is there any other discussion of the amendment? Yields back. Is there any further discussion? Seeing none, if there's no further discussion, the vote occurs on the amendment. All in favor so signify by saying aye. Aye. All opposed, nay. The ayes have it, and the amendment is agreed to. Is there any further discussion on the amendment or the bill? Seeing none, the question now occurs on forwarding H.R. 4534 as amended to the full committee. The roll call has been requested, and the clerk will call the roll.
Guthrie?
Aye.
Guthrie votes aye. Burgess? Latta? Aye. Latta votes aye. Griffith? Griffith votes aye. Bilrakis? Bilrakis votes aye. Bouchon? Bouchon votes aye. Hudson? Carter? Dunn? Pence? Pence votes aye. Crenshaw? Crenshaw votes aye. Joyce? Balderson? Balderson votes aye. Harshbarger? Miller Meeks? Obernolte? Obernolte votes aye. Eshu? Sarbanes? Cardenas? Cardenas votes aye. Ruiz? Ruiz votes aye. Dingell? Custer? Custer votes aye. Kelly? Kelly votes aye. Barragan? Barragan? Barragan votes aye. Blount Rochester? Blount Rochester votes aye. Craig? Craig votes aye. Schreier? Schreier votes aye. Trahan? Pallone? Pallone votes aye. J. Rogers? J. Rogers votes aye.
Anyone seeking to answer the roll call? Gentlelady from, how's gentlelady from California recorded?
Ms. Eshu is not recorded.
Aye.
Gentlelady?
Eshu votes aye.
Gentleman from Maryland?
Mr. Sarbanes is not recorded. Sarbanes votes aye.
Seeing no others, the clerk will report.
Chair Guthrie, on that vote, there were 21 ayes and 0 noes.
With 21 ayes and 0 nays, the bill is agreed to. The chair calls up H.R. 670 and asks the clerk to report.
H.R. 670, a bill to amend Title IV of the Public Health Service Act to direct the Secretary of Health and Human Services to...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Are there any, does anyone seek recognition on the bill? On the bill or the amendment? Anyone on the bill? Are there any bipartisan amendments? Are there any other amendments? The lady from New Hampshire is recognized.
Thank you, Mr. Chairman. I'd like to strike the last word.
Well, would the chair, would the clerk report the amendment?
Amendment in the nature of a substitute to H.R. 670, offered by Ms. Custer.
Without objection, the reading of the amendment is dispensed with, and the gentlelady from New Hampshire is recognized for 5 minutes in support of her amendment.
Thank you, Mr. Chairman. My amendment would direct the Department of Health and Human Services to establish a publicly available website where people with disabilities and their caregivers and families can find information about Medicaid services and supports available to them and how to use them. For example, people with disabilities and their families would be able to use this database to find information about home and community-based services available near them and how to access them. In states with lengthy wait lists, the website will have information on expected wait times. This simple proposal would make the complicated system that many people with disabilities and their families navigate far more accessible. I hope that we can work together to improve more expansive changes to improve access to home and community-based services for the many people who rely upon them. And I yield back.
The gentlelady yields back. Any further discussion on the amendment? Seeing none, any amendments to the amendment? Seeing none. If there's no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All opposed, nay. The aye has it. The aye has it, and the amendment is agreed to. Is there any further amendments? Seeing none, the question now occurs on forwarding H.R. 670 as amended to the full committee. Roll call has been requested, and the clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess. Latta.
Aye.
Latta votes aye. Griffith. Griffith votes aye. Bilrakis. Bilrakis votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Dunn. Pence. Pence votes aye. Crenshaw. Joyce. Balderson. Harshbarger. Miller Meeks. Obernolte. Obernolte votes aye. Eshu. Eshu votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Custer. Custer votes aye. Kelly. Barragan. Barragan votes aye. Blount Rochester. Blount Rochester votes aye. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye. Mr. Dunn is not recorded. Dunn votes aye.
Anyone else seeking recognition for purpose of answering the roll call? Seeing none, the clerk will report.
Mr. Guthrie, how is Mr. Balderson recorded?
Has Mr. Balderson recorded?
Balderson votes aye. Chair Guthrie, on that vote, there were 20 ayes and 0 noes.
With 20 ayes and 0 nays, the bill is agreed to. The chair calls up H.R. 8084 and asks the clerk to report.
H.R. 8084, a bill to amend Title 19 of the Social Security Act to require states to verify.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? On the amendment or the bill? Do you,
On the bill.
on the bill, the gentleman from Florida is recognized for 5 minutes.
Thank
to
you.
speak on the bill.
Thank you, Mr. Chairman. I appreciate it very much. Move to strike the last word. Thank you. I want to speak in support of my bipartisan bill, H.R. 8084, the Leveraging Integrity and Verification of Eligibility for Beneficiaries Act, which I'm proud to co-lead with my colleague, Representative Angie Craig. The Live Beneficiaries Act would address concerns that were raised by the reports from HHS Office of Inspector General, which found that a number of states repeatedly have made incorrect capitation payments per member per month to the managed care organizations after enrollees had died. My simple bill would address this by requiring states to check the Social Security Administration's death master file on a quarterly basis and disenroll deceased beneficiaries from their rolls so that MCOs can't profit off of them improperly. This is a common sense policy to prevent unnecessary payments going to managed care plans and ultimately saving state Medicaid program money. At our legislative hearing, I asked Medicaid Director Tsai about this particular issue, and since we have introduced this bill, CMS has started to recognize this problem and take some administrative steps with states. This bill will help ensure we are abiding by good governance standards in statute. We know that too often fraudulent and wasteful payments occur in the Medicaid and Medicare programs, and we should continue to find ways to cut down and save taxpayer dollars wherever possible. So I ask my colleagues to support H.R. 8084, and I yield back the balance of my time, unless someone owns my time. I'll yield back.
Gentleman yields back, and the chair will recognize the gentlelady from Minnesota for 5 minutes for support of the bill.
Thank you so much, Mr. Chairman. I move to strike the last word. Great. Thank you so much, Mr. Chairman. I am so proud today that my bipartisan bill, the Live Beneficiaries Act, is included in the markup, although it's a little bit silly that we continue to have to promote this legislation. This bill would prevent Medicaid capitation payments from being issued on behalf of deceased enrollees to Medicaid managed care organizations. I want to thank Representative Bilirakis for his partnership and his common sense piece of legislation. According to a recent HHS Office of Inspector General report, an audit of just 14 states found that more than $249 million in improper Medicaid capitation payments were made to MCOs on behalf of deceased enrollees between 2009 and 2019. Of that, OIG found that over $3.5 million in improper payments were made on behalf of deceased enrollees to MCOs in my home state of Minnesota. When I came to Congress, I promised I would work across the aisle to seek and reform the way government works. Our bill makes important reforms to the government's oversight of taxpayer dollars. By tackling this waste, we can make room to fund important priorities like the home and community-based services that so many Medicaid beneficiaries rely on. In closing, I believe that my colleagues and I have a duty to take on fiscal responsibility. However, I refuse to balance the budget on the backs of our most vulnerable populations by slashing critical health care programs. Our bill is about improving the integrity of the Medicaid program and making sure that Congress remains a good steward of taxpayers' hard-earned dollars. Mr. Chairman, I thank you for the time, and I yield back.
Thank you. The gentlelady yields back. Is there any further discussion? Seeing none, the question now occurs on forwarding H.R. 8084 to the full committee. A roll call has been requested, and the clerk will call the roll.
Guthrie.
Aye?
Guthrie votes aye. Burgess. Latta.
Aye.
Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Dunn. Pence. Pence votes aye. Crenshaw. Joyce. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Obernolte. Obernolte votes aye. Eshu. Eshu votes aye. Sarbanes. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Custer. Custer votes aye. Kelly. Bardagan. Bardagan votes aye. Blow Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye. Mr. Dunn is not recorded. Dunn votes aye.
Anyone else seeking to answer the roll call? Seeing none, the clerk will report. This guy's coming back.
Chair Guthrie, on that vote, there were 18 ayes and 0 noes.
Excuse me, would the clerk report again?
Chair Guthrie, on that vote, there were 18 ayes and 0 noes.
With 18 ayes and 0 nays, the bill is agreed to. Just inform the committee, we got some members at budget hearing going, or budget votes that are going forward today. We also have members, so we're going to move to, on your list, to HR 7858. 7858. Make sure everybody is aware. And the chair calls up HR 7858 and asks the clerk to report.
H.R. 7858, a bill to amend Title 18 of the Social Security Act to establish a Medicare incident to modifier for mental health services furnished through telehealth. Be it enacted by the Senate and the House of Representatives of the United States of America and Congress assembled. Section 1, short title. This act may be cited as the.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Is there any discussion on the bill? Are there any bipartisan amendments? Because they speak on the bill? Or, I have an Ains. You want to speak on the Ains? And I bring the Ains up? Okay. So I will recognize myself, the chair, Mr. Clerk, I have a chair at the desk. I have an amendment at the desk. I have a chair at the desk as well. I have an amendment at the desk. Yeah. And the clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 7858, offered by Mr.
Without objection, the reamendment is dispensed with, and I will recognize myself for 5 minutes in support of the amendment. I'm offering this amendment in the nature of a substitute. This is to Congressman James Bill, since he's not on the subcommittee, and this amendment would expand the scope of the introduced bill to not only better our understanding of expanded access to mental health services provided via telehealth, but all telehealth services. By knowing what type of providers are delivering which service in telehealth, we'll be able to be more certain that telehealth patients are receiving appropriate care. This policy also aligns with HHS OIG recommendations and was one of their primary suggestions when they briefed this committee on their telehealth work. So this is a policy that is good for beneficiaries and good for program integrity, and I encourage my colleagues to support the amendment and final passage of the bill. And I will yield back and recognize the gentleman from California for 5 minutes to speak on the amendment in the nature of a substitute.
Yes, thank you, Mr. Chairman. Telehealth services are a game changer indeed, especially for rural communities that disproportionately experience the burden of healthcare workforce shortages and transportation barriers. But as we discuss telehealth legislation, we also need to be thinking about the importance of reliable internet connectivity, because you can't have telehealth if you don't have reliable internet connectivity. Without reliable broadband and access to the required technology, you see, telehealth doesn't work. That's why it's so important to extend and fully fund the Affordable Connectivity Program. The Affordable Connectivity Program subsidizes the cost of internet services for families, but it expires at the end of the month. Allowing this program to expire will raise costs for families that are already struggling to afford internet service. This program is crucial in rural communities like my congressional district. 1 in 5 households in the state of California is enrolled in this program. In fact, 1 in 3 in my district, and 38% of households in my district are enrolled. That's 111,964 households. So many families rely on this program to pay for the internet services they need for their telehealth appointments, for their work, for their education, and more. So I seriously urge my colleagues in this subcommittee to support extending the Affordable Care Program so that all of these telehealth bills can actually be of use to our constituents. With that, would you like my time, Representative Custer?
Sure.
All right, I yield to our Representative Custer.
Like many others today, I'm frustrated to be sitting here 2 weeks before the Affordable Connectivity Program ends with no clear path to keep this program funded. In New Hampshire alone, the ACP has helped nearly 40,000 households connect to the internet, allowing Granite Staters to apply for jobs, to access health care, and to participate in online education. This isn't a red state or blue state issue. This program benefits all Americans, regardless of where they live. And it's especially beneficial for rural patients who've come to rely upon the program to access video telehealth services, as we're discussing today. And yet, House Republican leadership refuses to add more funding to the program. 23 million Americans will lose access to the internet. And I'm hoping that my colleagues on this committee will join me in finding a permanent funding solution for the ACP to help keep rural and underserved communities connected. And with that, I yield back to Dr. Ruiz.
Would the gentleman yield?
And I yield to Representative Eshoo.
Excuse me. I thank the gentleman. I just wanted to add another statistic to this issue. Close to 50% of the enrollees in the ACP are military families. That should be yet another motivator. So I thank the gentleman for yielding, and I yield back to him.
And, for those who say that ACP is too expensive, for every dollar spent on the ACP program, the nation's GDP increases by almost $4. Telehealth visits are 23% less expensive than in-person visits. And to those who say ACP eligibility is too wide, the ACP has proven to be a crucial benefit for millions of American households, including over 10 million military families and 4 million veterans nationwide. So I need to ask, do our active service members and veterans not deserve access to affordable internet? We can have the conversation about eligibility, but ultimately we need to find a path forward for this program to ensure the millions of Americans who rely on it can stay connected to their doctors, their loved ones, and each other. And with that, I yield back.
Thanks. The gentleman yields back. Is there any further discussion on the amendment? The gentleman from Indiana is recognized to speak on the amendment.
Yeah, I move to strike the last word.
Gentleman's recognized.
I want to thank my colleagues across the other side of the aisle. I'm going to talk on the Affordable Connectivity Program. Look, 55,000 people in my congressional district are benefiting this. I just want to note that the Senate, at this point, has not offered us a solution and sent that to the House. We've also really have not been asked to work on reforms to the program that would earn our support to fund the program. We cannot just keep the COVID-era program going without taking a look at what reforms would be needed to ensure the program reaches households that need it the most. Again, 55,000 people in my district are participants in this. However, members on the committee, in a bipartisan way, are participating in a, it's bipartisan, bicameral USF working group. So we're working on a solution to ensure that the Affordable Connectivity Program is sustainable long-term, and I would encourage everyone on the committee, all of my colleagues, to help support that effort so that we can have an ACP program with some needed long-term reforms that makes it sustainable so that all of our constituents can benefit from this program. I yield back.
Would the gentleman yield?
Gentleman yield.
Sure.
I believe there is a Senate version. I've been talking to my colleague, Senator Peter Welch, who is working with our colleague, Senator J.D. Vance. And my most recent conversations with Senator Welch are that there are up to a dozen Republicans joining in that bipartisan version. And so noting all of the constituents, particularly, and I think our chair our ranking member may have a chart that's helpful on this. We're talking about rural communities. We're talking about, red states and blue states. And so I hope that there will be a bipartisan solution, and I hope with your leadership, we'll be able to work with our speaker to get that to the floor. And with that, I yield back.
I reclaim my time. Yeah, I'll yield.
Thank you. Mr. Chairman, I'd also just love to touch on the Affordable Connectivity Program. It has been incredibly useful in the state of Washington. 1 in 8 households in the state have saved money. We've even seen private industry, the internet service providers, respond by establishing plans that only cost $30 a month, so that so many of these people, the ones in the most need, actually can get high-speed internet at their homes or at their businesses for free. This has been incredibly successful. It elapsed last month, and I just don't think we should be waiting for the Senate to take action on this. Let's renew this program while we're waiting for a permanent solution. This has helped students, people in rural communities access healthcare. It has helped businesses thrive. And I think we need to bring this to the floor immediately and not wait for the Senate. With that, I will yield back.
Reclaiming my time, as I reiterated again, there's a bipartisan, bicameral working group, and I think everyone is working towards a solution to ensure that the Affordable Connectivity Program is sustainable long-term. And again, I would encourage everyone to work together on this program. Mr. Chairman, I yield back.
Gentleman yields back. Is there further discussion? We were on the Ains. So if there's no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All opposed, nay. The ayes have it. Well, now, the question now occurs on forwarding H.R. 7858 as amended to the full committee. A roll call vote has been requested, and the clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess.
Burgess votes aye.
Burgess votes aye. Latta.
Aye.
Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu. Eshu votes aye. Sarbanes. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Custer. Kelly. Badagan. Badagan votes aye. Blount Rochester. Craig. Schreier. Schreier votes aye. Trahan. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye.
Anyone here to answer the roll call? Ms. Custer?
Ms. Custer, you are now recorded. Custer votes aye.
Dr. Joyce?
Dr. Joyce is now recorded. Joyce votes aye.
Anyone? Ms. Craig?
Ms. Craig is not recorded. Craig votes aye.
Anyone else seeking to answer the roll call? Seeing none, the chair will report. The clerk will report. Long day.
Chair Guthrie, on that vote, there were 22 ayes and 0 noes.
22 ayes and 0 nays. The bill is agreed to. Now alert the committee. We will move to H.R. 8111. 8111. The chair calls up H.R. 811. Start over. H.R. 8111 and asks the clerk to report.
H.R. 8111, a bill to amend Title 19 of the Social Security Act to ensure the
Without objection, the
reliability-
first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Are there any discussion on the bill? The gentlelady from Iowa, Dr. Miller Meeks, is recognized for 5 minutes.
Thank you, Mr. Chairman. I move to strike the last word.
Gentlelady's recognized.
My bill, H.R. 8111, the Medicaid Program Improvement Act, co-led by Congressman Cartwright, would create a process for state Medicaid programs and managed care organizations, or MCOs, to obtain address information of program beneficiaries to ensure that they are not enrolled in multiple state Medicaid programs. This simple, good governance legislation would maintain program integrity and help control unnecessary costs to states and to the federal government without restricting access to those who legitimately qualify for Medicaid. I thank the committee for moving my bill and urge my colleagues to vote yes. Thank you, Mr. Chairman. I yield back the balance of my time.
Gentlelady yields back. Is there any discussion? Seeing no further discussion, are there any bipartisan amendments? Are there any other amendments? Seeing none. Well, actually, I will, so we'll move to, okay, seeing none. Well, since I've already moved forward, so I didn't see it. We will move to the vote on the bill. The question now occurs on forwarding HR 111 to the full committee. All those in favor, the clerk, roll call has been asked, and the clerk will call the roll.
Guthrie? Guthrie votes aye. Burgess?
Votes aye.
Burgess votes aye. Latta?
Aye.
Latta votes aye. Griffith? Griffith votes aye. Bilirakis? Bilirakis votes aye. Bouchon? Bouchon votes aye. Hudson? Carter? Carter votes aye. Dunn? Dunn votes aye. Pence? Pence votes aye. Crenshaw? Joyce? Joyce votes aye. Balderson? Balderson votes aye. Harshbarger? Miller Meeks? Miller Meeks votes aye. Obernolte? Obernolte votes aye. Eshu? Eshu votes aye. Sarbanes? Cardenas? Cardenas votes aye. Ruiz? Ruiz votes aye. Dingell? Custer? Custer votes aye. Kelly? Bardagan? Bardagan votes aye. Blow Rochester? Craig? Craig votes aye. Schreier? Schreier votes aye. Trahan? Pallone? Pallone votes aye. Chair Rogers? Chair Rogers votes aye.
Are there anyone seeking to answer the roll? Seeing none, the clerk will report.
Chair Guthrie, on that vote, there were 22 ayes and 0 noes.
22 ayes and 0 noes, the bill is agreed to. The chair calls up H.R. 8089 and asks the clerk to report.
H.R. 8089, a bill to amend Title 19 of the Social Security Act to require certain additional provider screening under the Medicaid program.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point, so ordered. And I will recognize myself for 5 minutes to speak on the bill. I think all of the ones I think we have 4 bills today dealing with Medicaid, bringing these bills forward about improper payments in Medicaid. According to the Congressional Budget Office, federal spending on Medicaid is expected to increase from around $550 billion in fiscal year 2023 to almost $800 billion in fiscal year 2033, and that does not include state spending. Improper payments in Medicaid reached $50 billion in 2022. The OIG even stated that there is a compelling need to prioritize government program integrity, protect against improper payments. The 4 bipartisan bills we're marking up today represent small but important steps to addressing key issues facing state Medicaid programs. Included is frequently checking for deceased enrollees, address verification for enrollees, and ensuring providers are eligible to submit claims to Medicaid programs. Without these reforms, state lawmakers will be forced to potentially make tough decisions to cut certain health care services and put vulnerable patients at risk of losing health care coverage they may need. I would like to thank Representative Bilirakis, D'Esposito, Garcia, and Miller Meeks for leading on these bills. Also like to thank my good friend, Chair of the Rules Committee, Dr. Burgess, for leading on these bills. And I encourage my colleagues to support the legislation today. And I will yield back. Does anyone seek further recognition on the bill? Are there any bipartisan amendments? Are there any other amendments? The doctor from Texas, Chair Burgess is recognized.
Thank you, Mr. Chairman. I have an amendment to desk.
Clerk will report.
Amendment in the nature of a substitute to H.R. 8089, offered by
Without
Mr.
objection, the reading of the amendment is dispensed with, and the doctor from Texas is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. So 8089 is a very straightforward bill. Requires states to regularly check the Social Security Administration's death master file for doctors who are enrolled in their Medicaid programs and to remove doctors who are already dead. It sounds simple, but it can be serious. In the wake of the Change Healthcare attacks, we know now more than ever that hackers are looking for any way to exploit our system. And then when a doctor dies, their National Provider Identification, or NPI, is not immediately deactivated. The NPI of the deceased physician is low-hanging fruit for a hacker to steal and then to begin initiate a Medicaid billing cycle. It's a perfect crime because, of course, the doctor is dead and not going to be checking to see if there are any suspicious activity occurring on their NPI. The amendment incorporates technical assistance that was given by the agency. We need states to be more accountable in preventing fraud and removing deceased doctors from the Medicaid program so that they can't be subject to fraud after death is one of the easiest things we can do and safeguards their legacy. I yield back.
The gentleman yields back. Is there further discussion on the amendment? Seeing no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All those opposed, nay. The ayes have it, and the amendment is agreed to. The question now occurs on forwarding H.R. 8089 as amended to the full committee. All those in favor, a roll call has been requested, and the clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess. Burgess votes aye. Latta.
Aye.
Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Bouchon. Hudson. Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu.
Aye.
Eshu votes aye. Sarbanes. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Custer. Custer votes aye. Kelly. Barragan. Barragan votes aye. Sloan Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Pallone. Pallone votes aye. Joe Rogers. Joe Rogers votes aye.
Anyone seeking a roll call? Seeing none? Dr. Bouchon?
Mr. Bouchon is not recorded. Bouchon votes aye.
Anyone else seeking to answer the roll call? Seeing none, the clerk will report.
Chair Guthrie, on that vote, there were 22 ayes and 0 noes.
With 22 ayes and 0 nays, the bill is agreed to. So next will be, I think we're back in order now, 8112. So I think somebody moved it in my book. There we go. The chair calls up H.R. 8112 and asks the clerk to report.
H.R. 8112, a bill to amend Title 19 of the Social Security Act.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? I believe, Mr. Carter, you have an amendment. Is there any discussion on the bill? Seeing none, any bipartisan amendments? Seeing none. Mr. Carter, you're recognized.
Mr. Chairman, I have an amendment at the desk for H.R. 8112.
The clerk will report the amendment.
Substitute for the amendment in the nature of a substitute to H.R. 8112. Offered by
Without
Mr.
objection, the
Carter.
reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. Mr. Chairman, H.R. 8112 is simple. We should not let bad doctors into the Medicaid program. One way that we try to maintain the integrity of the program is by entering doctors into the data exchange, or DEX, which is a database managed by CMS that monitors doctors who have been terminated from the Medicaid and Medicare programs. To be clear, doctors are not removed casually from either program. You have to commit fraud or harm to patients in order to be terminated from the programs. The issue here, though, is that states are not always actively checking the decks. If a doctor breaks the law in Florida and is removed from Florida's Medicaid program, the doctor will be entered into the decks. However, if Georgia or another state doesn't check the decks, we may inadvertently let the doctor into our state. This bill is straightforward, and I hope we can all agree that keeping bad doctors out of Medicaid is in everyone's best interest. Thank you, Mr. Chairman, and I yield back the remainder of my time.
The gentleman yields back. Is there any further discussion on the amendment? If there's no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye.
Aye.
All opposed, nay. The ayes have it, and the amendment is agreed to. Are there any further amendments? Seeing none, the question now occurs on forwarding H.R. 8112 as amended to the full committee. And the roll call has been requested, and the clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess.
Burgess votes aye.
Burgess votes aye. Latta.
Aye.
Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Bouchon. Hudson. Carter.
Aye.
Carter votes aye. Dunn.
Aye.
Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu.
Aye.
Eshu votes aye. Sarbanes. Cardenas. Cardenas votes aye. Ruiz. Dingell. Ruiz votes aye. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Barragan. Barragan votes aye. Blount Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Pallone. Pallone votes aye. Joe Rogers. Joe Rogers votes aye.
Anyone seeking to answer the roll? Dr. Bouchon?
Mr. Bouchon is not recorded. Bouchon votes aye.
Anyone else seeking? Seeing none, the clerk will report.
Chair Guthrie, on that vote, there were 23 ayes and 0 noes.
With 23 ayes and 0 noes, the bill is agreed to. The chair now calls up H.R. 6033 and asks the clerk to report.
H.R. 6033, a bill to require the Secretary of Health and Human Services to establish a task force.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? Are there any bipartisan amendments? Are there any other amendments? The gentleman from Florida is recognized, offered an amendment.
Bipartisan amendment, an amendment in the nature of a substitute.
The clerk will report.
Amendment in the nature of a substitute to H.R. 6033.
Without objection, the reading of the amendment is dispensed with, and the gentleman from Florida is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Chairman. I want to offer this Ains. It's a bipartisan bill, bipartisan amendment, H.R. 6033. I ask my colleagues to support the amendment. The Supporting Patient Education and Knowledge, or SPEAK Act, is designed to increase access to telehealth services for those who may experience barriers to traditional telehealth care, such as those with disabilities or those with limited English proficiency. Studies have shown that these Medicare patients utilize telehealth at significantly lower rates, potentially leading to worse outcomes and leaving a key access tool out of reach. My amendment inserts the provisions of the bipartisan bill I co-lead with Representative Steele, H.R. 7863, the Expanding Language Access in Telehealth Act, to direct HHS to develop best practices to improve language access and other factors, particularly when patients are seeking behavioral health services through telehealth. We've seen in recent years how valuable telehealth can be for expanding access to critical behavioral health treatment, but it has become apparent that some seniors need additional support to fully utilize this tool in an effective manner. Our bill ensures that providers and patients receive training and support they need to take full advantage of this essential tool. These best practices include potential use of interpreters or audio-only services when video is unavailable, and additional training materials on how to access digital portals and multi-purpose video technologies. HHS would be required to consult with electronic health experts and remote patient monitoring companies, providers in hospital settings, and health and language quality certification organizations to disseminate this information. This common sense amendment supports patients and caregivers in the Medicare program and allows seniors to better access the full array of telehealth tools, particularly when managing their mental health. So I urge passage of this particular amendment and, of course, the underlying bill. And I'll yield back unless somebody needs my time.
Gentleman yields back. The gentleman from California seeks recognition for 5 minutes to speak on the amendment.
I move to strike the last word.
Gentleman's recognized.
I want to quickly discuss the value of H.R. 6033, the Supporting Patients Education and Knowledge Act, that I'm excited to co-lead with Representative Steele and a number of my colleagues on both sides of the aisle. The relationship between patients, healthcare providers, and the health system at large is the cornerstone of quality healthcare delivery. This legislation demonstrates a bipartisan commitment to helping ensure access to care across the United States for people with limited English proficiency. As we expand innovative technologies and telehealth services, we have a responsibility to the 25 million non-English speaking households in the United States. Developing and implementing best practices to overcome barriers ensures that every individual, regardless of their linguistic background, receives the care they need and deserve. I thank my colleague, Congresswoman Steele, for co-leading this bill, and I urge members of the committee to support it. And with that, Mr. Chairman, I yield back.
The gentleman yields back. Is there any further discussion on the amendment? If there's no further discussion, the votes on the amendment, all those in favor shall signify by saying aye. Aye. All those opposed, nay. The ayes have it, and the amendment is agreed to. The question now occurs on forwarding HR 6033 as amended to the full committee. The clerk will call the roll.
Guthrie.
Aye.
Guthrie votes aye. Burgess.
Burgess votes aye.
Burgess votes aye. Latta.
Aye.
Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Bouchon.
What if you could just do your?
Hudson.
I don't think you can.
Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu. Eshu votes aye. Sarbanes. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Barragan. Barragan votes aye. Blum Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye.
Anyone else seeking recognition for the roll call?
How's Mr. Bouchon recorded?
Mr. Bouchon is not recorded.
Aye.
Bouchon votes aye.
The chance to vote? All right. The clerk will report.
Chair Guthrie, on that vote, there were 23 ayes and 0 noes.
With 23 ayes and 0 nays, the bill is agreed to. 7620, we're back in.
Okay, got it. Chair now calls up H.R. 7623 and asks the clerk to report.
H.R. 7623, a bill to amend Title 18 of the Social Security Act to make permanent certain telehealth flexibilities.
Without objection, the first reading of the bill is dispensed with, and the bill will be open to amendment at any point. So ordered. Does anyone seek recognition on the bill? Recognize the ranking member.
Thank you, Mr. Chairman. I move to strike the last word and express my support for the bill. The bipartisan legislation would extend key telehealth flexibilities until the end of 2026 for 2 additional years. The expansion of telehealth flexibilities during the COVID-19 public health emergency and subsequently in the Consolidated Appropriations Act of 2023 has allowed millions of Medicare beneficiaries to receive access to necessary care. And expanding access to telehealth services during the public health emergency helped save lives and helped keep providers afloat. Since then, further expansion of telehealth services has helped provide critical services to hard-to-reach populations and help beneficiaries in areas that are already underserved. Now, MedPAC has found that telehealth utilization and spending has increased substantially, and the use of telehealth services among Medicare beneficiaries has continued to remain high and far above pre-pandemic levels. And while we've seen several tangible benefits to telehealth, I believe it is important that further expansions meaningfully increase patient access to care and ensure high-quality care for beneficiaries. And I'm pleased we were able to reach bipartisan agreement to include language in the legislation that will provide CMS with the tools and data necessary to monitor the quality of healthcare services that beneficiaries are receiving. CMS must be able to assess and monitor the quality of health services that Medicare beneficiaries are receiving. And I'm also pleased the legislation includes language that will help strengthen program integrity and ensure that telehealth is being used appropriately. But the last thing I wanted to say is that it's critical that we ensure equitable access to telehealth services, and many Democrats have talked about this today. Telehealth can help underserved individuals access care and help individuals who are managing serious health conditions. However, we know that many Americans lack the technology or internet access needed to use telehealth effectively. And the American Connectivity Program has helped 23 million low and middle-income households and an estimated 64 million individuals access the internet. But because of Republicans' failure to extend the program, American families are at risk of losing internet access they need for work, school, and health care, including telehealth. So I'm happy that my Republican colleagues are so supportive of telehealth, but I call on them to join our efforts to save this critical program and renew funding, because otherwise, how are people going to access telehealth if they don't have access to the internet? There's a chart behind me here that talks about the significance of the households enrolled in the Affordable Connectivity Program in the various states of Republican members, but I could hold up a similar one for Democratic members as well. And so I look forward to working with members of the committee to advance this bill through the full committee, and I thank the many members who have been leaders on this issue, such as Representatives Dingell, Blunt, Rochester, Matsui, Custer, and Eshoo, and urge my colleagues to support this proposal. And thank you, Mr. Chairman.
Gentleman yields back. Anyone else seek recognition to speak on the bill? Ms. Dingell? He's got an Ains. This is on the bill.
Okay.
You recognize 5 minutes.
Thank you, Mr. Chairman. I'm just respectful of my Republican colleagues at all times. I move to strike the last word on this bill.
Gentlelady is recognized.
Thank you. Telehealth provides a critical way for patients to access needed care. I'm proud to be a co-lead of H.R. 7623, the Telehealth Modernization Act. This legislation would remove originating and geographic site restrictions, which would allow patients to access telehealth from their homes and would support patients in both rural and urban areas. This legislation would also make permanent the ability of federally qualified health centers and rural health clinics to provide telehealth services and provide adequate reimbursements in those settings to ensure continued provision of virtual services. Strengthened access to health self-services can benefit many at-risk seniors, enabling them to continue accessing important health care services while remaining safe in the comfort of their own homes. During the April 10th legislative hearing, I asked patient advocate Ms. Jeanette Ashlock how extending telehealth flexibilities impacts the quality and continuity of care, And she said it's essential to have that tool of telehealth because all of us are different. Some of us have mobility issues. Some of us can't get transportation. Telehealth can get the care I need without the stress of getting to the doctor. I'd like to share another story, this time from a provider in my district regarding the benefits. I worked with a young adult navigating severe anxiety and panic attacks and have seen them make great progress through engaging in regular telehealth services. They live in a rural community within the service area of Packard Health, and with limited family resources, they struggle with transportation. Having the option to do telehealth therapy has made a tremendous difference. We simply would not have been able to do therapy consistently in person, which would have hampered our ability to provide effective mental health services. These services are critical for helping all patients access the care they need. I really appreciate the bipartisan coalition of members who have led this bill with me. Representatives Carter, Blunt Rochester, Stube, Sewell, Miller Meeks, Van Drew, and Morelli. I urge all of my colleagues to support this bill, and I do want to add to my ranking member's comment, and I missed my opportunity a little earlier to say people need to be able to have access. Those that can't afford transportation can't afford connectivity as well. So we must continue funding the Affordable Connectivity Program, ensuring millions of Americans aren't at risk of losing that connection and that opportunity the internet gives them to get health care. Of the 23 million families the ACP helps, 19% are seniors, 26% live in rural areas, and 49% are military families. We have to work to pass the bipartisan ACP Extension Act so that all Americans have access to the internet and we give them access by telehealth. I urge my colleagues to find a permanent solution, and I thank everybody for supporting this bill, and I yield back.
Gentlelady yields back. Anyone else seeking recognition on the underlying bill, Ms. Barragan? For what purpose do you seek recognition?
I move to strike the last word.
Recognized for 5 minutes to speak on the legislation.
Thank you, Mr. Chair. I move to strike the last word. I strongly support the telehealth extensions in the Telehealth Modernization Act. We saw through COVID-19 and the pandemic the challenges that it posed and how the conversation of telehealth and the use of telehealth was just expanded and highlighted the need for us to continue to build on telehealth. During the pandemic, temporary flexibilities allowed Medicare providers to offer a broader range of services via telehealth, especially for those who live in rural or underserved areas. It also led to increased access to critical health services for patients in urban areas, such as residents in my district. In Los Angeles County, a visit to a healthcare provider could mean hours of traffic. This can especially be a challenge for those with chronic conditions, older Americans, or people with mobility restrictions. As we move forward, it is critical we address the significant disparities that exist in access to telehealth use. Telehealth services are used less, for example, by Spanish-speaking patients. That's why I'm glad we are also marked up today the SPEAK Act, which would direct HHS to create a task force to identify best practices to improve access to telehealth for non-speakers. But as we've had this conversation, and I want to echo the comments of my colleagues, saying you're for something is different than acting on it. And I just kind of want to remind folks, it was when Democrats were in control of the House that we passed the infrastructure law. This was a $65 billion broadband investment that created the Affordable Connectivity Program, which is what's keeping people connected. Not a single Republican in this committee voted for the bipartisan infrastructure law. Yeah, you know what? These bills impact millions of Americans. And today, the people that are benefiting from these programs, and here's a chart so you can see how many of my Republican colleagues are benefiting, their constituents are benefiting from it. Yet I don't see a push to call the Speaker to make this urgent. The program ends this month. This is this month. There is no time. The time is right now to get together to move something on the House side. Just take a look at this chart, Representative Obernolte from California. 1 in 3 of his constituents are on the program. Over 92,000 people. Who's next in line? Let's see. Representative Lara, 1 in 4 people. 69,887 of his constituents. I would think that the members whose constituents are benefiting would be at the door of the speaker saying, hey, we're in charge now. We need to help our constituents keep their costs low. This is what Americans want. Not another week on appliances, but it's actually making sure that we move to pass and extend the Affordable Connectivity Program, because all these things we're doing on telehealth are gonna mean that millions of Americans will not have access. So let us do that, and let us work together, not just to talk about it, but to have action across the aisle. Because the last time I checked, Republicans were still in charge of the House. So we gotta continue, and I urge my colleagues on the other side to not just say here that you're for something. Move to get it passed as a discharge petition. Talk to your leader over there. But please, let's do this. It is so critically important, and it's ending now. There was an opportunity in the budget. We could have done it then. There has been opportunity after opportunity. So I'd like to see some action. With that, I yield back.
Generally yields. Anyone else seek recognition to speak on the underlying bill? Seeing none, are there bipartisan amendments to the bill? For what purpose does Mr. Carter seek recognition?
Mr. Chairman, I seek recognition to offer an amendment in the nature of a substitute to H.R. 7623, the Telehealth Modernization Act.
The clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 7623, offered by Mr. Carter. Strike all after the...
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of his amendment.
Thank you, Mr. Chairman. Mr. Chairman, I'd like to offer this bipartisan amendment that I'm leading with Representatives Lisa Blunt Rochester and Dr. Miller Meeks. As a pharmacist now serving in Congress, one of my top priorities has been improving the accessibility, affordability, and quality of health care, no matter where patients are located. Unfortunately, Americans living in rural areas too often have few to no health care options available close by and have a 43% higher mortality rate. Thankfully, this committee is considering my legislation, the Telehealth Modernization Act, to preserve patients' access to telehealth, which will help patients, particularly seniors and those in rural areas, access timely, high-quality health care. I often say that we knew how important telehealth was before the pandemic, but we didn't quite realize it until the pandemic. Telehealth has proven to be a safe and effective way to deliver care, especially for patients who live in rural communities far away from doctors, and it also helps seniors who may not have the ability to travel to a doctor. Telehealth has also proven to be an effective tool in addressing the healthcare workforce and physician shortages. Without congressional action, these Medicare telehealth flexibilities will expire at the end of this year, creating an access cliff for tens of millions of patients and providers. That is why I've introduced the Telehealth Modernization Act with Representative Lisa Blunt Rochester, which would extend these Medicare telehealth flexibilities and ensure access to care for seniors. The amendment before us today would preserve Medicare patients' access to telehealth through 2026, which is crucial for our seniors and those in rural and underserved communities. The amendment extends audio-only coverage to help increase accessibility for those in rural communities with limited or no access to broadband services. It also extends to the Hospital at Home telehealth program through 2029 utilizes health centers and rural health clinics to provide telehealth and makes important program reforms. I'm also pleased to see this bipartisan amendment include crucial pharmacy benefit manager reforms for my Protecting Patients Against PBM Abuses Act. This policy would delink PBM compensation from the cost of medications and increase price transparency, lowering the cost of prescription drugs for seniors. This will save taxpayers roughly $700 million and help reduce seniors' out-of-pocket drug costs. This is common sense, bipartisan policy that will protect seniors from some of the most egregious practices of PBMs and make prescription drugs more affordable.
While I am disappointed that we are not making these Medicare telehealth flexibilities permanent, I look forward to working with my colleagues on this committee to ensure that these vital telehealth services do not lapse. Increasing access to telehealth for Medicare beneficiaries means increasing access to quality care for our seniors. That is why I urge my colleagues to support the Telehealth Modernization Act. Thank you, Mr. Chairman, and I yield back the remainder of my time.
Gentleman yields back.
and
Anyone
last-
else seeking recognition to speak on the Ains? Ms. Miller Meeks, you recognized.
Mr. Chairman, I move to strike the last word.
5 minutes.
Thank you, Mr. Chairman. I'm glad to see the committee include my bill with Mr. Carter, H.R. 7623, the Telehealth Modernization Act, in the hearing today. This bipartisan legislation expands audio-only telehealth access for seniors and maintains provisions that were enacted last Congress, such as removing geographic and originating site restrictions for rural patients. Amongst other policies, the legislation also allows federally qualified health centers to furnish telehealth services. Unity Point, a hospital system in Iowa with locations and clinics in my district, had 1,689 providers serve 76,268 patients via telehealth in the past year. This resulted in over 160,000 telehealth visits, with 94% of them occurring in the outpatient setting with high levels of patient satisfaction. Telehealth allows seniors, especially those in rural areas, to have consistent and reliable access to their physician, which is critically important for individual and public health. I urge my colleagues to support this legislation and yield back the balance of my time.
Generally yields back. Anyone else wishing to speak on the Ains? Seeing none, if there's no further discussion, a vote now occurs on the amendment. All those in favor signify by saying aye. Aye. All those opposed, nay. The ayes have it, and the amendment is agreed to. Are there any other amendments to the legislation? Seeing none, the question now occurs on forwarding H.R. 7623 as amended to the full committee, and a recorded vote has been requested. The clerk will call the roll.
Guthrie. Aye. Guthrie votes aye. Burgess. Latta.
Aye.
Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Carter votes aye. Dunn. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Balderson. Balderson votes aye. Harshbarger. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshu. Eshu votes aye. Sarbanes. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Custer. Custer votes aye. Kelly. Barragan. Barragan votes aye. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye.
Does any other member seek recognition to vote? Ms. Dingell?
Ms. Dingell votes aye.
Anyone else wish to be recorded? Seeing none, the clerk will report.
Chair Bouchon, on that vote, there were 21 ayes and 0 noes.
The ayes have it, and the bill is agreed to. Chair calls up H.R. 1406 and asks the clerk to report.
H.R. 1406, a bill to amend Title 18 of the Social Security Act to permanently extend certain in-home cardiopulmonary rehabilitation flexibilities.
Without objection, the first reading of the bill is dispensed with, and the bill will be open to amendment at any point so ordered. Does anyone seek recognition on the bill? Recognize the ranking member. 5 minutes.
Thank you, Mr. Chairman. I move to strike the last word.
5 minutes.
During the COVID-19 public health emergency, the CMS waived a number of provisions in the Medicare program, including temporarily allowing certain cardiac and pulmonary rehab programs to be reimbursed for services supervised virtually in a patient's home. Now, these waivers were critically important because Medicare beneficiaries were some of the most vulnerable to COVID-19. As Congress considers further extensions of these policies, it's important for us to carefully consider the impact of these changes on our healthcare system. I've been supportive of cardiac rehab, which consists largely of nutrition, counseling, and supervised exercise, and I know that that model has helped many people. But the cost of cardiac rehab is substantial and can have out-of-pocket costs of as much as the thousands of dollars for beneficiaries. So we need to make sure that beneficiaries are getting good value for their dollars. Under this bill, patients who receive these services virtually would be subject to significantly higher cost sharing than if these services were delivered in a physician's office. The bill would reimburse for cardiac rehab provided virtually at the same rate as a hospital outpatient department, and I'm not sure if the significantly higher reimbursement rate is appropriate or cost-effective. So we need to ensure that Medicare beneficiaries are getting good value for the dollars. We also need to review the scoring from CBO and understand the proposed offsets for any increased costs. And I look forward to working with my colleagues to determine if there may be a bipartisan path forward. With that, I yield back.
Gentleman yields back. Any further discussion on the underlying bill? Seeing none, are there any bipartisan amendments to the bill? Recognize Dr. Joyce. What purpose do you seek recognition?
Mr. Chair, I have an amendment in the nature of a substitute at the desk.
The clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 1406, offered by Mr. Joyce. Strike all.
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of his amendment.
Thank you, Chairman. I speak today in strong support of the aims to H.R. 1406, the Sustainable Cardiopulmonary Rehabilitation Services in the Home Act. This important legislation will open up access to virtual intensive cardiac and pulmonary rehab services for our nation's seniors so that they are able to heal and recover at home from severe cardiac and pulmonary episodes. H.R. 1406 improves access to much-needed care, especially among underserved populations, and has been demonstrated to improve chronic care and cardiovascular outcomes. Every year, more than 1 million Americans will have a heart attack, bypass surgery, or other cardiac events that will make them candidates for these rehab services. The data shows that completing a cardiac rehab can increase life expectancy by 5 years and reduce hospitalizations by 30%. Despite CMS and CDC having set a goal of having 70% of patients complete this rehab, unfortunately, we are currently only at 8% completion among those eligible patients. One of the most commonly cited reasons for why there is a lack of success is the lack of access and the challenges associated with commuting to a hospital twice a week for these services over the 3-month prescribed period. Fortunately, one of the very few silver linings of the COVID-19 pandemic was that we saw an expansion in access with seniors being able to access these services virtually at home through their original telehealth flexibilities. Virtual cardiac rehab results in an overall 18% reduction in costs to the system and a 38% reduction in hospitalizations. Similar results were seen in pulmonary rehab for patients with conditions like COPD, which showed that there is a cost-effective program that also reduces hospitalizations and ultimately improves the quality of life. This bill would restore this access to our seniors and ensure that they have greater access to the necessary cardiac and pulmonary services at home. I urge my colleagues to support this legislation, and I yield the balance of my time.
Gentleman yields back. Is there any one seeking recognition? Seeing none on the amendment. If there's no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All those opposed, nay. The amendment is agreed to. The question now occurs, the question now occurs on forwarding H.R. 1406 to the full committee. All those in favor shall say aye. Aye. All the opposed, no. The ayes have it, and the bill is agreed to. The chair calls up H.R. 7856 and asks the clerk to report.
H.R. 7856, a bill to amend Title 18 of the Social Security
Without
Act.
objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek recognition on the bill? Is anyone, are there any bipartisan amendments? Are there any other amendments? The gentlelady from Washington is recognized.
Thank you, Mr. Chairman. I move to strike the last word.
Gentlelady is recognized.
Mr. Chairman, I would first like to thank our committee leadership, Congresswoman DeGette and Congressman Bilirakis for working to move this proposal forward. As a pediatrician and someone who's managed my own type 1 diabetes for just about 40 years, I understand the importance of prevention and a healthy lifestyle. The Medicare Diabetes Prevention Program is a health behavior change program to help Americans with pre-diabetes prevent it from progressing to type 2 diabetes. The program includes up to 16 weekly group sessions over a 6-month period, and then follow-up sessions over the next 6 months that involve training to make realistic, long-lasting behavior changes around diet and exercise. The program is provided at no cost to eligible seniors on Medicare and has been shown to improve the health and lifestyle of participants, decreasing the chances of type 2 diabetes. Using CMS's own words, the reach of the MDPP has been very limited. An estimated 16 million Americans aged 65 or older are eligible for MDPP, the Diabetes Prevention Program, but fewer than 5,000 beneficiaries have participated as of 2021. Expanding this program to allow virtual participation would be extremely impactful for seniors, especially those who live in rural areas. There are no MDPP, Diabetes Prevention Program suppliers in my entire district, which spans 10,000 square miles. That is a serious access problem. This amendment would allow virtual providers to participate in the MDPP over 2 years. Virtual care for lifestyle change programs like this one work. All you have to do is look at the CDC's National Diabetes Prevention Lifestyle Change Programs, many of which are offered as part of this MDPP program. Some of those programs offer a 100% virtual option that participants can choose over in-person sessions. The CDC recognized programs have been shown to improve health and prevent diabetes when provided virtually, and there is no reason why the same wouldn't be true as part of the MDPP. So while I'm disappointed that we weren't able to find a way to permanently authorize this program, I'm very happy that this AINS makes virtual care part of the MDPP demonstration for 2 years. I look forward to working with Congresswoman DeGette and Congressman Bilirakis to make this program permanent next Congress. I urge my colleagues to support my amendment in the nature of a substitute and the underlying bill, and I yield back the balance of my time.
I have to offer the amendment. So will the clerk report the amendment?
Amendment in the nature of a substitute to H.R. 7856, offered by
Without
Mr.
objection, the reading of the amendment is dispensed with, and the gentlelady is recognized to discuss her amendment. I believe you discuss your amendment.
Thank you, Mr. Chairman. As you have heard, this is an important way to make diabetes education and prevention available virtually, and I encourage my colleagues to support this amendment. Thank you. I yield back.
Thank you. The gentlelady yields back, and the gentleman from Florida is recognized for
Thank
5
you.
minutes to
I
discuss the amendment.
appreciate it. Thank you. I move to strike the last word.
Gentleman's recognized.
Thank you, Mr. Chairman. I want to thank Representative Schreider for her partnership and support of our underlying bill that I lead with Representative DeGette, the Prevention Diabetes Act, which expands on the Medicare Diabetes Prevention Program, which is an effective program that has been proven to help patients lower their risk for developing diabetes. The expanded model will allow CDC-recognized virtual suppliers to participate in the program and additional access points to delay the onset of diabetes. It will save significant taxpayer dollars and prevent complications as a result of this chronic disease. Unfortunately, rather than the underlying bill's permanent solution, the AINS narrows the scope down to a 2-year pilot program, and I'm concerned that this will not allow CMS enough time to properly develop the new components or gather enough data for this program to be before we have to come back and extend it again. So I am concerned, Representative Schreier. Thanks for bringing that up as well. I'm also concerned that the amendment removes the flexibility that seniors be allowed to access the program more than once in their lifetime, since we know that evidence-based interventions may be required for diabetes and prediabetes patients more than once. So we will lose a key way to enhance the program's effectiveness. While I'm cognizant of the potential costs involved in setting up this bill and will support what we already have here in this committee, whatever the committee agrees to, I'd like to continue to work with the chair and the ranking member to find a pathway forward that will make a meaningful impact on the diabetes communities. Thank you very much, Mr. Chairman. I do ask for support of this AINS, and I yield back the balance of my time, and obviously, I support the underlying bill.
Thank you. The gentleman yields back. Are there any further discussion on the amendment? If no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. Those opposed, nay. The ayes have it, and the amendment is agreed to. The question now occurs on forwarding H.R. 7856 as amended to the full committee. All those in favor shall say aye. Aye. All those opposed, no. The ayes have it, and the bill is agreed to. The chair calls up H.R. 5394 and asks the clerk to report.
H.R. 5394, a bill to ensure appropriate access.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So order, does anyone seek recognition on the bill? The amendment or the bill? The bill? The bill, you have the amendment? So the gentlelady from Illinois is recognized for 5 minutes.
Mr. Chair, I move to strike the last word.
Gentlelady's recognized.
Affordable, reliable internet service is a necessity, not a luxury, especially as families continue to navigate virtual learning, working from home, and telehealth appointments. Unfortunately, internet service can be expensive, and too many people are left behind when it comes to internet access. The Affordable Connectivity Program has proven to help people stay connected even when monthly budgets are tight. In my district, 79,530 households have enrolled, or 1 in 4 households have saved money on their internet bills because of the ACP. I thank the Biden-Harris administration who worked with internet providers to offer high-speed internet plans that are fully covered by the ACP. Many working families in Illinois have been getting high-speed internet for free. Congress needs to act promptly to provide an extension to this benefit and other extensions in telehealth. My district is urban, suburban, and rural. ACP has helped low-income and rural communities connect to the internet. In perspective, lack of broadband access means that some expecting mothers can't even have a basic telehealth appointment. I encourage my colleagues to support my bicameral legislation, H.R. 5886, promoting Access to Broadband Act, which would make grants available to inform eligibility to programs like the ACP. I also ask for support for H.R. 5394, expanding Remote Monitoring Access Act, championed by Rep. Balderson, my co-chair of the Digital Health Caucus. I would like to thank you and your staff for your ongoing work on remote patient monitoring, especially for seniors. Both bills ensure no person is left outside innovation and access, but to have better care in the long term. Thank you, and I yield back.
Gentlelady yields back. Anyone else seeking discussion on the bill? Gentlemen, you have a bill or on the amendment? Gentleman from Florida is recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate it. I want to briefly express my support for this bill and the amendment, and I thank Representative Balderson for his leadership on the Remote Monitoring Access Act. Remote monitoring has been proven as a way to ensure patients are managing and maintaining their health conditions from the comfort of their home. We should continue to expand on this option for our seniors wherever it is feasible. One way in which this is done very effectively is through remote chronic anticoagulation therapy for patients who have had a stroke, artificial heart valves, or history of blood clotting. To ensure that the proper levels of blood thinning is achieved, providers closely monitor these levels through the international normalized ratio testing, which can be conveniently done in the patient's home. And while INR testing is already covered by CMS under the National Coverage Determination, unfortunately, patients have to go in person for 3 months in order to be eligible for the home-based INR testing, despite home testing proven to be more effective and leading to higher adherence and better outcomes. We should remove this unnecessary requirement. I'm working on a policy that would remove this requirement for home INR testing. I'd like to work with the committee and with sponsors of this bill further to ensure that these patients have these effective telehealth and remote patient flexibilities. And again, I commend Representative Balderson for his good work on this particular piece of legislation. I support the AINS and, of course, the underlying bill. I yield back.
Will the gentleman yield?
Yes, please. I will.
Thank you, Mr. Bilirakis. I'll keep my remarks brief, but I do want to quickly discuss a point of concern regarding H.R. 5394 and the other telehealth legislation notice for today's hearing. Whether you want to call it telehealth or telehealth, telehealth has emerged as an informative tool in healthcare, but a tool is only helpful if you have access to it. 1 in 3 of the households in my district depend on Affordable Connectivity Program, otherwise known as ACP, to facilitate their access to the tools that the internet offers. The ACP has been critical in ensuring equitable access to the internet benefiting my district, as well as historically underserved low-income rural communities across the United States. Many of these households already are struggling to make ends meet, face the alarming prospect of being disconnected from what has become a necessity in their lives. Ensuring that low-income and rural households have affordable internet access through ACP is vital to the success of our efforts to integrate telehealth services into our health system. I urge my colleagues to commit to telehealth accessibility and to ensuring that access to affordable internet is available to as many American households as possible, especially when this is required and necessary if telehealth is going to reach everyone that we want it to reach. With that, I yield back to Mr. Bilirakis.
And I'll yield back.
Gentleman yields back. Is there any other discussion on the bill? Gentleman from New Jersey,
Thank you, Mr. Chairman.
recognized for speaking on the bill.
Thank you. It is important that we properly vet the implications of any bills we're considering in committee, and it's unclear what problem this bill is trying to address. But under current law, Medicare can reimburse for remote monitoring when data is collected 16 out of 30 days a month. It's also unclear to me whether lowering that threshold to just 2 days of data collection for remote monitoring services is appropriate. And in fact, I've heard concerns that 2 days may not be appropriate. I'm not sure we're getting good value for Medicare beneficiaries who will need to pay cost sharing for these services. And it's important that we prevent potential bad actors from taking advantage of the system and seniors. I also understand that we still don't have feedback from the Congressional Budget Office, so I'm looking forward to receiving this feedback and understanding how the majority plans to offset the additional spending. But I just want to mention that I will not support any policies that are not a good value for seniors or raise premiums or increase out-of-pocket expenses. So thank you again, and I yield back.
Gentleman yields back. Is there anyone seeking discussion on the bill? The gentlelady from Delaware.
Thank you, Mr. Chairman. I move to strike the last word.
Gentlelady's recognized.
Thank you, Mr. Chairman, and I want to thank the committee for your support of the Telehealth Modernization Act that I championed and co-partnered with my friend, Congressman Buddy Carter. And as we continue to debate legislation related to telehealth, we must also acknowledge the basic infrastructure that allows people to take advantage of these life-saving telehealth services, connectivity. We know that 24 million Americans lack reliable high-speed internet, which has become essential for accessing work, school, and telehealth services we are discussing today. We also know that the #1 barrier to access is cost. That's why we came together on a bipartisan basis last Congress to create the Affordable Connectivity Program, which helps families who are struggling to afford their internet bills stay connected. 23 million Americans enrolled, a historic success in expanding broadband access. And in Delaware, more than 52,000 households enrolled in this program. That is 1 in 8 households. We hold this markup at a critical moment for the ACP and for families in my state and yours that need this lifeline. I came from a state that is urban, suburban, rural, and coastal. So we experience diverse challenges, but we all have the universal need to stay connected. In 2024, the internet is not a luxury, it's a necessity. I've heard from many of my constituents, including a constituent from Wilmington who lost her husband and is living with a disability, who will be directly impacted if we fail to extend this program. Funds are running out and are set to expire imminently. My constituents have asked me to help make sure that doesn't happen, and I intend to do everything in my power to make sure it does not. The Affordability Connectivity Program plays a vital role in connecting our constituents to their healthcare providers, and I urge my colleagues to work together to extend the program as swiftly as possible. Thank you, and I yield back.
The gentlelady yields back. Seeing no further discussion on the bill, does anyone have a bipartisan amendments? Or are there any other amendments? The gentleman from Ohio is recognized for 5 minutes. Well, gentlemen, to report at your amendment.
Thank you, Mr. Chairman. I have an amendment in the nature of a substitute at the desk.
Clerk will report.
Amendments in the nature of a substitute to H.R. 5394.
Without objection, reading the amendment is dispensed with, and the gentleman from Ohio is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. Appreciate that. And also this markup, including my bill, H.R. 5394, the Expanding Remote Monitoring Access Act. This amendment makes a minor technical adjustment to the bill to address comments we received from CMS. During the pandemic, I was introduced to remote patient monitoring when a hospital and an FQHC in my district showed me firsthand their successful RPM programs. These programs were made possible by a waiver that has since expired and which I believe needs to be reinstated. RPM empowers patients to better manage their chronic conditions while enabling healthcare providers to adjust treatment plans and promptly identify critical events from a distance in real time. This technology can reduce provider workload while giving them greater access to patient feedback and data to identify problems earlier. In rural communities like mine, where healthcare providers are scarce and patients often face challenges accessing traditional care facilities due to distance, these services are especially helpful. However, when the waivers expired, CMS went back to only paying for RPM when physicians receive at least 16 days worth of data per month. As our doctor colleagues on this committee will tell you, sometimes they need to be able to monitor their patients for a week, sometimes 2. Cardiovascular patients, diabetics, and those with renal disease are just a few of those who can benefit from remote patient monitoring. But under CMS policy, these patients are left without access unless they give 16 days of monitoring data each month. Our bill follows the model Congress established for our own telehealth flexibilities. This bill extends for 2 years coverage of remote monitoring for patients who need at least 2 days of monitoring each month. This interim solution ensures patients receive the necessary care while Congress and CMS develop a comprehensive long-term plan. Patients will receive better care because they are empowered to personally manage their healthcare conditions. Medicare will see lower costs in the long run because these devices will catch catastrophic events earlier. We're already seeing the patient benefits and cost savings from expanded RPM use. A study by the University Hospitals in Ohio projected that remote monitoring could potentially lead to 87% fewer hospitalizations, 77% fewer deaths, and reduced per-patient cost of over $11,000 compared to standard care. After equipping patients with RPM for 6 months, Ochsner Healthcare System found that 79 of their hypertensive patients achieved blood pressure control, and 81% of enrolled type 2 diabetes patients met their blood sugar levels. The University of Alabama at Birmingham extended remote patient monitoring to 17,000 beneficiaries within the accountable care organization, including those with congestive heart failure, chronic kidney disease, diabetes, and hypertension, resulting in a savings of $1,300 per month per member. This markup is especially timely given the ongoing delays from the AMA, CPT panel, and inaction from the CMS in last summer's PFS rulemaking. Patients who have benefited from remote patient monitoring cannot wait any longer, and it is encouraging to see this subcommittee take action today to lead on increasing access to this critical care. I look forward to working to continue expanding access to these valuable technologies and encourage my colleagues to join me today in supporting this amendment and the underlying bill. Thank you, Mr. Chairman. I yield back.
The gentleman yields back. Is there any further discussion on the amendment? Seeing none, if there's no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All those nay. The ayes have it, and the amendment is agreed to. The question now occurs on forwarding H.R. 5394 as amended to the full committee. All those in favor say aye. Aye. All those opposed, no. The ayes have it, and the bill is agreed to. The chair calls up H.R. 1199 and asks the clerk to report.
H.R. 1199, a bill to amend Title 18 of the Social Security Act to ensure...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? The gentleman from New Jersey is recognized for 5 minutes.
Thank you, Mr. Chairman. I understand the important role that diagnostic radiopharmaceuticals have in diagnosing, monitoring, and managing diseases properly. Radiopharmaceuticals? And in improving patient outcomes. It's important that we ensure payment rates for these services do not jeopardize or limit patients' access to necessary care and create unsustainable financial burdens for providers. However, I believe any solution to this should not raise out-of-pocket costs for Medicare beneficiaries. Unbundling items that are currently included in a bundle payment means that beneficiaries will have new and significantly higher costs or higher out-of-pocket costs. So I'm pleased that the bill protects beneficiaries from increased out-of-pocket costs, and it's critical that we preserve this important consumer protection. I would not be able to support this policy unless we can ensure that Medicare beneficiaries are fully protected from any cost increases associated with paying separately for diagnostic radiopharmaceuticals. I'm also concerned that technical assistance provided by CMS has not yet been incorporated. I understand that we are still waiting for feedback from the Congressional Budget Office, and I want to ensure the bill does not result in increased costs to the Medicare program or for seniors. I also want to ensure that the budget neutrality provision does not jeopardize patients' access to care. I don't think it's good precedent for us to make an across-the-board cut to hospitals every time that Congress wants to pay for a new service or item separately, because over time, I believe this will result in distortions in our payment systems. But again, look forward to working with my colleagues to determine if, what path forward exists, and I would yield back, Mr. Chairman. Thank you.
Gentleman yields back. The chair recognizes Dr. Dunn for 5 minutes to speak on the bill.
Thank you very much, Mr. Chairman. I'd like to speak in favor of the FIND Act, H.R. 1199, which will help seniors receive better care. I'd like to thank my colleague, Mr. Peters, for working with me for several years to advance this important common sense solution to improving diagnostics for a wide array of patients. I'm passionate about access to cancer screening, and I devoted a large part of my career to treating prostate cancer. I've seen it affect my family, colleagues, and many, many patients. I also know far too many who have suffered from Alzheimer's and Parkinson's disease. The FIND Act aims to align Medicare reimbursement for advanced radiopharmaceutical diagnostics with their value and their cost. Screening saves lives. When a physician can obtain an accurate diagnosis early
we can achieve the best outcome for patients. Modern radiopharmaceutical imaging is far more sensitive and accurate at diagnosing many diseases, both benign and malignant. And when we avoid unnecessary treatments due to inaccurate scans, Medicare saves money. So not only is advanced screening a money saver for the system and the taxpayer, it's often a matter of life and death. The Facilitating Innovative Nuclear Diagnostics Act, or FIND Act, H.R. 1199, seeks to empower doctors and patients to determine the correct diagnosis and do it as early as possible. 13 of my colleagues on this committee are co-sponsors. Last year, Medicare solicited for comment 5 proposals which could have remedied the current payment inequity during their rulemaking. Unfortunately, Medicare did not adopt any of those policies in the final rule. Our support for the FIND Act shows we support our seniors who have prostate cancer, Parkinson's disease, Alzheimer's disease, metastatic breast cancer. The list goes on and on and on. Today, I urge my colleagues to support the FIND Act so that patients in their districts have access to the most advanced and accurate diagnostics. And with that, anybody?
Gentlemen yield.
I will.
Just thank you. Innovations greatly improve the ability to detect and treat a slew of life-threatening diseases such as prostate cancer, Alzheimer's disease. And the FIND Act is an important solution to ensure patients access to a new generation of radiopharmaceutical diagnostics that will improve patient outcomes and save lives. By voting to advance this legislation today, providers will have more tools at their disposal to address the most urgent needs of seniors and help increase the quality of life for them and their families. I appreciate and encourage a yes vote, and we yield back.
I do.
Yield back. The gentleman yields back. Any further discussion? There was seeing no amendment. We'll move to the question now occurs on forwarding H.R. 1199 to the full committee. All those in favor say aye. Aye. All opposed, no. The ayes have it, and the bill is agreed to. The chair calls up H.R. 4758 and asks the clerk to report.
H.R. 4758, a bill to amend Title 19 of the Social Security Act to streamline.
Without objection, first reading, the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Is there any discussion on the bill? Dr. Miller Meeks from Iowa. You're recognized for 5 minutes to speak on the bill.
Thank you, Mr. Chairman. I move to strike the last word.
Gentlelady's recognized.
Thank you, Mr. Chairman. I'm proud to see the committee marking up the Accelerating Kids Access to Care Act, which would streamline administrative processes for providers who need to enroll in another state's Medicaid program due to a lack of services provided in the patient's home state. I was also proud to have a fellow Iowan and constituent, Dr. Alex Basuk, testifying before the committee in February to support this legislation. As a physician who practiced in a river community, it was not unusual for us to have patients come to us from Illinois or Missouri to seek care in Iowa. There is currently no standardized federal pathway for this process, meaning that providers must enroll in a state's Medicaid program whenever they see a new patient from that state and must maintain regular paperwork to remain enrolled in each state's Medicaid program. When a child from a new state is visiting a doctor, as may be the case if a child from another state travels to Iowa for care, there are often delays in care as the providers sift through weeks of paperwork, risking the health of children with critical life-threatening conditions. One case that clearly speaks to the need for this bill involves an 11-year-old from another Midwest state who has a very rare and serious condition known as mid-aortic syndrome, in which the aorta narrows, leading to multiple serious complications that can result in death if untreated. In this case, a referral was made from another children's hospital to Boston Children's Hospital, which operates a leading program to address this condition, and a comprehensive care plan was assembled in April of 2022. In the case of the child's home states, all providers at Boston Children's needed to be enrolled in the home state's Medicaid program before the state would authorize this care. By July 2022, the enrollments were still pending, which led to a cancellation of care that had been scheduled for the following month, August of 2022. The home state did not complete its enrollment of the Boston Children's providers until November of 2022. In early 2023, Boston Children's assessed the child, and a comprehensive care plan that included additional providers given the child's specific condition was assembled.
A request for authorization was submitted in May of 2023, and the care was ultimately provided in September of 2023, nearly a year and a half after the initial contact occurred. Again, I am proud to see this committee move this critical piece of legislation, and I encourage my colleagues to support it. With that, I yield back.
Gentlelady yields back. Is there any further discussion? The gentlelady from California is recognized.
Thank you, Mr. Chairman. I move to strike the last word and
Gentlelady's
speak on the
recognized.
bill. Thank you. More than 84 million people are enrolled in Medicaid and the Children's Health Insurance Program, which, of course, provide health coverage to children in all 50 states and the District of Columbia. Children enrolled in Medicaid often have to travel to other states when there's a specialized treatment or health service that isn't available in their home state. Thousands of children and their families traveled to Lucile Packard Children's Hospital at Stanford, which is in the heart of my congressional district. And over the years, there have been members themselves as parents who have traveled to Lucile Packard for the specialized services that they offer there. We should make it easier for children with Medicaid coverage to receive the specialized care that's there for them and be able to cross state lines and actually to get that care. The Accelerating Kids Access to Care Act does just that. I'm proud to support it. I urge all the members of our committee to vote for it so it can become law this year. Children in need of life-saving care really should never be made to wait, and this legislation addresses that. I thank the authors of the legislation, and I yield back, Mr. Chairman.
Gentlelady yields back. The chair will recognize anyone on the Republican side. The gentleman from New Jersey for 5 minutes.
Thank you, Mr. Chairman. I want to speak in support of the bill because I'm excited that we're moving forward on this critically important bill today and one step closer to it becoming law. I'm going to just kind of summarize, but I wanted to mention that during the legislative hearing in February, we heard stories of children who had to wait months to receive the care they needed, all due to unnecessary red tape and bureaucracy. And this status quo really helps no one, because children's care needs can become more complex as time goes on, leading to increased safety risks, worse outcomes, and more intensive treatments. Providers have to invest countless hours in addressing states' disparate screening and enrollment processes. And for the parents and caretakers, ensuring one of the few providers who can care for their children is enrolled in their state Medicaid program adds to their overwhelming stress that they face every day. So this bill obviously helps to alleviate that burden and expedite out-of-state care for children when needed. It creates a pathway for pediatric providers to more easily enroll in out-of-state Medicaid programs, but still maintains the program integrity. So it is very important, and I just want to add to why I think, let me thank Chair Rogers again, and also Representative Trahan for putting this forward, and I yield back.
Thank you. The gentleman yields back. Is there any further discussion on the bill? Any bipartisan amendments? Are there any other amendments? Seeing none, the question now occurs on forwarding H.R. 4758 to the full committee. All those in favor say aye. Aye. All opposed, no. The ayes have it, and the bill is agreed to. That concludes the legislation before us. And without objection, the staff is authorized to make technical and conforming changes to the legislation approved by the subcommittee today. So ordered. Without objection, the subcommittee stands adjourned.